So hello everyone. I'd like to take hello everyone. I'd like to take this opportunity to thank you all so much for joining us today. Welcome to day 2 of the African Youth AMR Forum. Yesterday we had our first session, which was very informative. So welcome to day 2. My name is Katrina from KEPSA, Kenya. Today I'll be moderating with my fellow coordinator, Shade. Kindly introduce yourself.
Hi everyone, my name is Shade Alice Carlton from PSFGH Ghana, and I'll be your co-moderator. It's good to have you all here.
So as we wait for our first speaker, I'll just go through my takeaway of the previous session. So yesterday we had a phenomenal lineup of speakers. My biggest takeaway was the profound connection between the SDGs and the antimicrobial resistance. The speaker really emphasized that each SDG is okay. So before our first speaker joins, let me go through a bit of what we learned yesterday. So yesterday we had a phenomenal lineup of speakers. My biggest takeaway was the profound connection between SDGs to AMR. So the speaker emphasized that addressing each SDG is very crucial for a successful fight against antimicrobial resistance. So briefly today, we're going to have a series of icebreaker questions as well as amazing speakers lined up for us. I want to assure you it won't be boring at all. It will be very exciting. So I hope you have a pen and a notebook somewhere to jot down important points. I actually have mine here. So yeah, and a bit of housekeeping rules. Kindly, let's keep our microphones muted at all times unless given the floor to speak. And after each speaker's presentation, we'll be taking a few questions from the chat. So feel free to share your comments or questions in the chat. Yeah. So without further ado and to save on time, I'll just go through an introduction of our first speaker for today. So our first speaker goes by the name Michael Mosha. Mr. Michael is a pharmacist with a specialization in public health. He's driven by a strong passion for combating antimicrobial resistance. With a background in as an M&E officer and a project lead, he currently serves as the head of operations at the RBA Initiative, a registered Tanzanian NGO dedicated to addressing AMR. So Michael brings a wealth of experience in engaging local and international stakeholders in AMR projects. He is the lead He's the lead of AMR and NCDs at the African Youth AMR Alliance Task Force, in other words, IRTF, and he's also a member of the quadripartite FAO, UNEP, WHO, and WOAH Youth Working Group on AMR. His his work reflects a deep dedication to addressing the AMR crisis through a One Health framework, emphasizing the interconnectedness of human, animal, and environmental health. Currently, at the RBA initiative, he heads a diverse range of project activities that target AMR at the grassroots level. These include a research project on impacting antibiotic dispensing, going beyond stricter enforcement, RBA AMR school clubs, where school children are educated on AMR, as well as AMR awareness programs for journalists, healthcare professionals, religious leaders, public transport workers, and the community at large. So his team also employs healthcare interns through the bridging program, enhancing their skills in antimicrobial stewardship. Michael Mosha exemplifies a commitment to having AMR at both the local community and international levels. His leadership and focus on education and collaboration continue to drive impactful solutions for a healthier future. So for the next 25 minutes or so, Mr. Michael will take us through AMR and NCDs, the overlapping threats to global health. Welcome, Mr. Michael. Thank you so much for honoring our invite and taking time off of your busy schedule to be with us. The floor is yours.
Thank you very much. And hi, everyone. Thank you for the introduction. Moderator, maybe would you allow me to present, to share my screen? So yes, hi everyone. I'm going to pass you through the overlapping topic on non-communicable diseases and AMR. I'll start with understanding concepts regarding AMR and non-communicable diseases. We know that non-communicable diseases refers to infections or chronic infections or conditions that are transmitted from person to person, are not transmitted direct from person to person. And we have vast of examples on this area, given that we have cancer and cardiovascular diseases, which is one of the major chronic infections in terms of NCDs that leads to the global burden of non-communicable diseases. And when it comes to antimicrobial resistance, is ability of microorganisms to resist the drugs that were initially capable of killing or inhibiting their growth, but they no longer work in an effective way. So just a note to remember that it's not the body that becomes resistant, but rather the organisms that do become resistant toward this toward these medicines. And this is a natural process, as we all understand at one point. Now, given that several literature says that non-communicable diseases lead about 71% of all death in the world, but some of the literatures tell us it leads by 74%. So there are several literatures, but the average is about 70% of all death are caused by non-communicable diseases. And we know the causes of these non-communicable diseases being genetic, physiological factors, genetic factors, but also, behavioral factors do contribute to non-communicable diseases. But there are risk factors that do accelerate non-communicable diseases. And we all know this, they're all based about lifestyles, regarding unhealthy diet, physical inactivity, and harmful alcohol abuse. But remember that maybe a message to take is that NCDs and their complications often lead to secondary infections. So the secondary infections from NCDs are the ones which we attribute to the overuse and hence AMR risk. And we are going to see this through the next slides. Now, what are the roles of antimicrobials in non-communicable diseases? We know that NCDs are complications of people with these chronic infections, such as diabetes and so on, are more susceptible to infections due to immunocompromised situation in the body. The immune has been depressed a bit, and now this leads to opportunistic infections. And these infections could be bacterial, fungal, or viral infections. Now, this probably person or individual with these chronic infections to be prone in the use of these antimicrobials. So now prolonged use of antimicrobials, as long as these infections are chronic and are long-term, in managing such infections, this can easily lead to AMR. Now, for instance, we could take people with diabetes and having a urinary tract infection, which is urinary tract infection is a secondary infection to diabetes. We know that due to sugar level being high, then the microorganisms are attracted to this environment. Hence, now you're probed to use these antimicrobials. Now, overuse of these antibiotics to treat urinary tract infections then can probe or can keep you in the risk of getting antibiotic resistance and hence AMR. Now, what is the context when it comes to AMR and NCD adjoining threat? First is increased vulnerability. As I said earlier, that people with these chronic infections are immunocompromised. The immune defense is very low, making them getting these opportunistic infections and possibly being probed to use these antimicrobials. So it increases the vulnerability of these individuals and making them prone to use these antimicrobials. But another issue, when you're prone now to use these antimicrobials, it can lead to the overuse of antibiotics, because these infections are long-term infections, and at one point a person will just having this behavioral aspect of just to use antibiotics to clear infections, sometimes not completing the dose and so on. Now, all this long-term management of chronic infections leads to the repetitive behavior of using these antibiotics. Let's say, for an example of diabetes and UTI, can promote antibiotic resistance. But also delayed treatment outcomes. It's not a thing that we can't ignore, because AMR complicates the treatment of secondary infections. Once you are having these resistant germs, and now you are more prone to, or you are prone to these secondary infections or opportunistic infections, then treatment becomes harder, and then it can lead to prolonged hospital stays, and also the cost of treatment do increase. You know that you can move from first line now and lead to third line generations of drugs, of which are a bit expensive, and hospital stays. But what are the shared factors now that can lead to, that makes this interconnectedness between AMR and NCDs? Lifestyle factors. I see that general lifestyle, this is including alcohol misuse, or abuse of alcohol, tobacco intake, and so on, and poor diet. And all these factors, again, it increases the susceptibility to infections. Why? Because the immune defense is lowered, and then it requires a person to use these antimicrobials once the secondary infections now start to manifest themselves. So lifestyle brings this link between NCD and AMR. But at one point, behavioral aspects, you are told to use your medications as required, but people decide to use otherwise, or because of using the previous illness experiences, I've been using this way, nothing has happened to me, I've been cutting short my course and all that, so I'm good to go. So that behavioral aspect now, it brings all the aspect of lifestyle to one place and highly contribute and brings this connectedness between NCD and AMR. But antimicrobial misuse in the general population, as I said, the behavioral aspect, and this also can align with the lifestyle issues. Inappropriate use, you are not prescribed, You are using them, using the previous illness experiences, such as, you want to treat viral infections using antibiotics. That will never work. So we need to stay on our lanes, to accept what our professionals tell us to do and follow. And through this is the way that we can mitigate AMR. Now, what are the strategies that we can put into action in combating this? One of the best ways is prevention. We know that prevention is better than cure, and it is necessary now to advocate for prevention. All the risk factors, the lifestyle and behavioral aspects that's negative in nature, that can promote NCD AMR, have highly to be tackled. Giving education on how better people can follow the instructions, but also staying healthy in terms of exercising, physical body exercises, and eating healthy can all promote good health and curbing NCD and AMR, because they're all connected. And rational use of antimicrobials. Yeah. Now, what happens if a person now has a genetic issue that has led to NCD? We have to promote the stewardship of antimicrobials. We have to tell, the healthcare providers have to play their role, but also the community members of the patients have to play a role. So how good are we telling these people to use the antimicrobials, to see a healthcare provider before using them? And once they have these antimicrobials, how better they store and use or follow the instructions that were provided to them. But also ensure appropriate prescribing and avoid overuse. This is a role for healthcare providers, to encourage completing prescribed courses to our patients, but the patients also have to play their role in ensuring that what is injected or what is provided to them is aligning to what we wish to, or what is intended to be achieved. But also infection control measures. Enhance infection prevention, healthcare settings and households. For instance, we have hand washing campaigns. These are practical and cheapest ways to tell people on how to curb NCD and AMR. We know that there are some of infections that was due to poor hand hygiene, and this is necessary now to bring into component of IPC wash on board and initiate these talks or stimulate these discussions with the NCD patients. But also, one of the key issues is to integrate policy approach. It is necessary now, we have to make links between NCD and AMR guidelines and strategies in place, because there's still these strategies that are written in silos. I'm an expert in NCDs, I have to write my own guidelines. Someone else is an expert in AMR, has to write his or her guidelines or strategies in place independently. But when we come all together to bring that multi-sectoral approach and multidisciplinary approach, then we can have this link and, find a better way on how we can approach NCD and AMR. So we should have this integrated policy approach. As of now, I know most of the policies are written independently, and, they don't bring that connectedness between these two things. Now, what is the way forward after all that discussion and seeing the link between NCD and AMR is that addressing one requires a holistic approach. We know that we have an umbrella of One Health approach right now. It's an agenda to everyone, and it's being advocated very well. But what we are preaching, is it put into action? That remains a question, because we still see most of the sectors and most of the healthcare providers still work in silos. And it's high time now to bring into action what we are preaching about, this holistic approach in curbing NCD and AMR, as we see with the climate change and so on. But collaborative approach. We need the government, the CSOs and NGOs, together with community members and healthcare providers, come all together and co-designing these interventions and these discussions. It's very healthy to have this approach, because at one point, as healthcare providers, you do not know everything, and the community members have something to say. And you also should appreciate that they do not know everything, and we have a place to share our views or perspectives. So it's necessary now to work in collaborative approach, and it's better now to move from the top-bottom approach and move from the bottom-up approach, whereby it touches the grassroots level, whereby the lay individuals have an opportunity to express their views and share the ideas that can provide better ways we can leverage these efforts. In conclusion, is that prevention of NCDs and antimicrobials is crucial for tackling AMR, and I mean NCDs and prudent use of antimicrobial is essential in curbing AMR and improving health outcomes. Without ignoring the fact that all these are interconnected, as I said earlier, we need to address this with an holistic approach, and yes, to come together with better collaborative disciplines in a way of addressing and in a way that we can integrate everyone in place so that we can promote this prudent use of antimicrobials and addressing NCDs so as to have this better health outcomes. Thank you very much. I submit.
Thank you so much, Mr. Michael, for that very insightful presentation. My biggest takeaway is the strategies to action that you've given us on how to address the link between NCDs and AMR, especially on the prevention of NCDs. So thank you so much. You've given us a lot to think about. Maybe we can take questions from the participants, if any. Okay, there's no question for now, but thank you so much. Thank you for your time.
Thank you very much.
See someone's hand is raised. Maxwell. Kindly you
Thank
can
you very
ask your
much. Can you hear
question.
me loud and clearly?
Yes.
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 Thank you
Hold
for this beautiful presentation. My name is Maxwell. I'm in Ghana School of Veterinary Medicine. Oftenly, I have realized that for some of us who are in school or some of us who are professionals, we understand some of these things. But when it comes to taking it from paper to action, the majority of the people that we are going to talk to are people that are on ground who do not understand some of these things. Once I speak, a lot of people think that antimicrobial resistance is a fallacy, because just like when our economic or finance minister reads the budget, we don't understand some indicators. So going forward, what specifically are the strategies that we can adopt so that the people that are on ground will be able to understand us perfectly? Thank you very much.
Did I respond, Magoma?
Please go ahead.
Thank you very
Mr.
much.
Michael, please go ahead.
Thank you. Thank you very much, Maxwell, for the good question of this is what I know a little bit about. And it's very, very true. We can't ignore the fact that we are learning a lot theoretically, but putting into practice. And this is what I was saying. where we have a lot of guidelines, policies, but putting them into action. So we keep on preaching, but putting them into action. Now, I can just respond by saying that one of the better ways or strategies to, reach the grassroots level is to create this bottom-up approach. With the bottom-up approach, whereby you co-designing the interventions together with the community members at the grassroots level, taking out very, very good people and come together and stay in one place and talk about what are their needs and demands. At one point, the problem that we are doing is that we sit at the offices and think that community X requires or has this certain demands or needs, but we need to go and sit down with them and talk to them. And once we do that, we co-design the interventions together, like, hey, we want to do A, B, C, because we have seen so far, we have behavior Y, behavior C, behavior A. Now, let's talk together. For instance, like sharing antibiotics could be one of the behaviors in the communities, and also just disposing of this microbial. Or unhealthy way of living, such as not doing exercises, eating healthy. Now, how are we talking to the communities? So using the simple language, but also after identifying these behaviors, now we can truly co-design these interventions, not going back to the office and say that, hey, we have discovered this, now let's just do this intervention. So with the intervention, with the co-designing of the intervention, it is necessary now to say, what do you think that is practical on their end, even if we are not there to discuss or to do, or we don't have the finance to promote the intervention, but we have to ensure the sustainability among themselves. Now, this comes with the co-designing. And with the co-designing, the impact of it is that it creates the ownership of the intervention that you have created with them. Because at one point, we failed to create this ownership. And with the ownership is when people feel that they have really endorsed their feelings, their perspectives, and their, ideas or opinions. So it's high time now as professionals that we should lower our ego at one point. I don't know a better way to say, but maybe our ego that we are healthcare providers or we are the experts in public health. We had know everything and the community members have to listen to me. So for me, I believe that we have to lower this, to bring down our professionals at one point and discuss what is relevant and designing this intervention with them, but not ignoring that we are healthcare providers or we are professional in this field and injecting our ideas that are aligning with what they need and what they want. So for me, I would say a thumb up to co-designing of these interventions, but also promoting the bottom-up approach rather than, bringing the policies and guidelines and say, hey, this is the way to go. It will never work out. Because people have experiences, vast of experiences. For instance, you will find a particular individual that has been, having these cardiovascular diseases for more than 20 years and will come to the hospital. You have to narrate what he or she has been, living for the rest of his or her life, or for the past 20 years of his or her life. So it's high time now to agree that they know, and what they know has a limit to us professionals, what we know. I submit.
Thank you so much, Mr. Michael. I think that's a very comprehensive response. Thank you so much once again for the insightful presentation. You've really given us a lot to think about. In case any of the participants have any questions, kindly raise your hand. You'll be given the floor to speak. Well, I think maybe there are no questions, so we can move on to the next presenter for today. So the next presenter is an invaluable resource person. I'm confident that you'll be delighted by the insights and expertise he has to share with us. So our next speaker goes by the name Mr. Eric Benant. Mr. Eric is a committed global advocate for antimicrobial resistance and a founder of the Roll Black Antimicrobial Resistance Initiative. His work centers on developing public and community engagement strategies and interventions informed by behavioral science. He also serves as the public engagement lead for the UK's MRC awarded project on AMR in sub-Saharan Africa. In other words, DAMS SSA. Eric has contributed to various technical antimicrobial resistance entities and supported the setup of the Stop Superbugs network under the British Society for Antimicrobial Chemotherapy, BSAC. With expertise in pharmacy, public health, and health economics, Eric is advancing community-based antimicrobial stewardship through his doctoral research and continues to contribute to global AMR mitigation efforts through various interventions. And so for the next 25 minutes or so, Mr. Eric will take us through financing AMR solutions, how to secure grants and write winning proposals for youth-led initiatives. So thank you so much, Mr. Eric, for honoring our invite. The floor is yours.
Thank you very much. I'm very delighted to be here and joining the second African Youth AMR Forum. And I would go direct to my presentation. And as it has been stated, I'll be focusing on financing AMR solutions, basically because as we already know, AMR poses a significant threat to global health. I'm very sure following the sessions you had, you already know how AMR is a global threat and jeopardizing modern healthcare in multiple sectors. But also Sub-Saharan Africa has the youngest population in the world. And according to the African Union, 7% of its inhabitants are under the age of 30. So it's obvious that youth and young people compose the huge population in Sub-Saharan Africa. So we really expect this population to contribute in different public health challenges, and in particular in this case when it comes to antimicrobial resistance mitigation efforts. And hence we need to strengthen funding and capacity building programs to support youth-led AMR interventions. That's very, very essential. So there's a huge importance of financing AMR solutions, as I've mentioned, but here I've highlighted a few points, and one is that we really need to translate the objectives of AMR global actions plans and national actions plans, and this task will really require multiple stakeholders, including youth. And the recent UN high-level political declaration on AMR cited this. We need multiple stakeholders, and it explicitly cited that young people should also be engaged in translating the objectives of global actions plans and national actions plans. We need to incorporate the whole of society approach to enable participation of multiple stakeholders. But also we really need to fund use AMR solutions because as we all know that young people are innovative, with a fresh perspective, with new ideas and solutions, and all these need both technical support and financial support to move forward. So we need to invest in capacity building and to come out with sustainable interventions and to ensure sustainability of the already established interventions. We really need to effective fund the use AMR solutions. So it's very, very important that young people are being given the tools, are being capacitated, and are having financial resources to carry out their innovative ideas in AMR mitigation efforts. So, this presentation is, or this session is focusing on financing use-led AMR solutions or interventions, but including the tips on how to write a good proposal and all those important issues. But one of the first aspects that I would like to highlight and emphasize here, it's first making sure that use-led AMR interventions, use-led AMR projects, use-led organizations have set a good governance and strengthening their systems to enhance the uptake of AMR projects, to enhance the uptake of financing resources. So here are very few points that I've highlighted, and this includes establishing accountability mechanism, having a clear governance and a clear structure that would establish an accountability mechanism to ensure not only the uptake of financial resources, but also the sustainability of the interventions, but also ensuring compliance with legal and donor requirements. And here in every context and every country or region or particular settings, there are normally legal requirements to follow. And all these are the key things to make sure that they are already existing before going to the next steps, and this will further strengthen the chances of use-led interventions or use-led projects to be able to work and have credibility to engage different stakeholders. The other thing is strengthening the operational systems for project implementation. So it's very critical that we have invested enough time to make sure that we strengthen operational systems that would enhance the appropriate implementation of a certain intervention or a certain project. So all these are some of the key aspects that you should take into consideration before even going to the next step of seeking funding for your project. But also, the last point, but not least, is engaging different stakeholders. Multiple stakeholders as part of your governance structure that would bring diverse perspective, diverse expertise and background, and strengthen your governance system as whole. So these are a few important issues that I would like to emphasize to be considered and to make sure that you put energy and the concentration and the efforts to build and have these clear governance and systems before taking further steps. Of course, you won't be able to put all these structures at once, but to ensure that you you have a good governance and a good accountability systems, a good operational systems that would enhance you to carry out your interventions and to carry out your projects. This includes issues like team building, some of the tools, reporting tools, and some of the monitoring and evaluation tools that would enhance you to uptake your intervention. The other issue is identifying the right funding sources. So there are a lot of funding sources and different funding sources. And here I've just mentioned a few, and this includes local partners and cloud funding. So this is the first step to start by engaging the local partners or doing a crowdfunding when you start with a small project or when you start with initial interventions, because you can't take next step of your project or of your intervention before starting at a small scale and building on what you have achieved to move forward. There are different international partners. Few of them are focusing on AMR, and other stakeholders has partners in broad angle, but also there are also other stakeholders which are, for example, focusing specifically to fund youth organization. I think some of the funders, for example, the PAR Foundation is really supporting AMR mitigation led by youth and different stakeholders. We have also some of the international partners who are focusing on AMR, like ICAS, and some of the organizations or partners that are focusing on HES, but they might be interested to fund some of the innovative interventions. We have private sector and philanthropic foundations, and also we have vertical funding mechanisms. This is where, for example, we have funding supporting malaria interventions, but we could then have a component of drug resistance malaria within it, or funding specifically for HIV, AIDS, or specifically for health emergencies, and then you could then explore on how you could have AMR within this kind of funding mechanisms. To mention, there are normal different types of funding, and I would just mention two types, like flexible funding. These are the funds provided without restrictions on how they are used, and then it gives the recipients the flexibility to allocate the resources where they're most needed, but of course by following the guidelines set by the donor. And the advantage is that they support organizational growth and innovation and enable quick response to emerging needs or challenges, as well as covering indirect costs. So this type of funding is very, very essential for startups, I can say, for the youth-led interventions, which are emerging, which are not well established. So you could normally look to these funding sources, these applications which are provide flexible funding, so that you can also have a good room to enhance your systems and to enhance your governance that would eventually support the implementation of the subsequent interventions. We also have project-specific funding, as the name suggests, that these are the funds for a specific project or program. So it's not it is not easy, or it is not allowed to reallocate the funds. So they provide clear focus and accountability and attracts funders with a keen interest in specific objectives. And now the limitations that they may not cover indirect or administrative costs, and reduces flexibility in reallocating resources. So when applying for these for the funding opportunities, you also have to make sure you know, is this flexible funding or is this project-specific funding? And then you tailor your proposal, you tailor your budget accordingly to make sure that you know which route it is kind of funding. And I will now move on to highlight key components of a strong proposal. And this is not, there's no one size fits all. So normally there is clear instructions and guidelines depending to the donor, depending to the funding agencies. So you just have to make sure that you follow and read the guidelines. But this is the normal key issues that are always being included in different calls. Problem statement, you just have to be innovative at every stage and to state clear the problem or the gap you want to address. And here you should be able to take time to invest and do kind of research, do a literature review to make sure that you know what is existing already in case of interventions, to know what is already out there, what are the scientific evidences available, and what are the gaps. And now, why do you want to address that gap? So you should be able to generate evidences and emphasize on why is that a particular problem of concern at your context, what has been done, and what you will contribute innovatively. And then you should be having clear and smart objectives. Normally, I would emphasize that the objectives should be measurable and should be very clear, easy to understand, and very explicit. You don't have someone who read your proposal to start then defining your objectives. They should be explicit. And the audience, you have to define the population or community you aim to work with and why they are critical in addressing AMR. So why are you targeting that particular population? And yeah, so you should be able to provide argument and evidence. Why do you think that population, that community is of concern? So that's why in every component here, you must be innovative as possible as you can. And the methodology, the approaches, you're trying the activities you will undertake and focusing on an innovative approaches. Normally, most of the interventions are existing. You just have to take time and read and know what has been done in Ghana, what has been done in Uganda, what has been done in DRC, what has been done in Senegal. And then you have to reflect on how you can come with the new approaches, or you can adapt the existing approaches at your context in an innovative way that would enhance and sustain the uptake of your intervention. Also think about other stakeholders. Who are the other stakeholders you will engage from the initial phases of co-developing, of co-creating your intervention and your projects? Because we need the sustainability of your project after at the end, even after the funding period the funding period is over, then we still need the sustainability mechanisms. So you should be able to think from the beginning who are the relevant stakeholders who you can co-create and co-develop the intervention together with. And one of the important issues, impact and evaluation. I think this is one of the core issue. You have to demonstrate how you measure the success and start reflecting what are your expected outcomes, what are your expected outputs, and what are your expected impact, and how are you going to measure? Will it be by doing surveys, for example, to measure maybe the knowledge change before and after? Will it be qualitatively by exploring or getting testimonies or narrative, or if it's a big research component? But normally for the projects, the short-term projects, then you should be able to demonstrate in terms of measurable indicators, if in terms of numbers, in terms of percentage, in terms of change, how are you going to assess the impact or to evaluate your project? And most which many people sometimes do not include just because they have not been asked to, its sustainability plan. But I think it's very, very important to put out that you aim to sustain this intervention even after the funding time is over. So you already have some of the initial thoughts on how are you going to sustain, even if not in a bigger scale, but on how are you going to make sure that what you have achieved after the project is also being rolled out, is being shared widely, and could be also adaptable. Budgeting is part of the core component of the proposal. So build a detailed and a transparent budget. A detailed that here I mean that you have to provide a clear breakdown of how funds will be used and ensure it aligns with funders' goals and the guidelines. That's why I've mentioned there is no specific structure. You just have to adhere to the guidelines and instructions provided in each specific call or in each specific funding route you have. But you just have initially to have a detailed budget, transparent budget, and then you can then adapt it and tailor it according to the templates being given or being needed. But you just have to be sure and to have a clear breakdown of how funds will be used by a line and adhering to the guidelines provided, but of course being realistic, being practical of what could be achievable. Don't be overambitious. Yeah, so you just have to be realistic, and we yeah. So to summarize on what I have explained above, for effective financing, you just need to do research, finding the right funders, starting in the AMR scope, go broader for health sector, one health lens. There are other routes which are very specific for use, not only in health, but use as a development area, and other specific areas where you can leverage AMR projects, or you can leverage use project or project. So researching potential donors, government bodies, NGOs, international organizations, and foundations focused on health, AMR, and all use development, as well as identifying priorities, what do funders want, highlighting areas where youth-led initiative intersect with their goals. Building partnerships is very, very important. You just have to start at this stage of building partnerships, and then that's how you'll be growing, and that's how you'll be able to implement projects starting at a small scale and then growing to large scale. So collaboration with established organizations or experts in the field, as well as youth-led organization working with you can also work close with health authorities, work close with universities or research bodies to make sure that you get a proper mentorship and guidance to implement your projects. I've already mentioned about adapting proposals to funder needs to understand the criteria, objectives, and expectations, and most important, to demonstrate the scalability and the sustainability of the project. These are highlighted 4 common mistakes to avoid: lack of clarity in objectives. You just funder need to understand what the project will achieve. So focus on how you evaluate and assess the impact or outcome. Alignment with funders' priorities, but of ambitious scope. So make sure your project is realistic and achievable within the proposed budget and time frame. Normally, you have to be very focused in a certain setting within a certain population and audience. So don't be overambitious that you just want to cover 3 regions while you don't have that capacity, you don't have that uptake. So it's better to do and focus in a small area that is realistic, that is achievable, but would really demonstrate how you can bring changes even when you will scale up to reach a broader audience and to engage the large population. I've talked about the evaluation strategies. How is it critical? And last 3, these are the things that I would like to highlight: strengthen organizational systems and the governance structure. Most of use, they skip organizational systems and structure. Build within the project, the interventions, to make sure that you are able to uptake the intervention, you are able to uptake the funding before applying. So if you see, okay, this application, it's not, I just have to take time to prepare myself, or we just have to take time to prepare ourselves, then take time, strengthen yourself, and then reapply again. Don't just apply for the sake of application while you don't have such kind of uptake, or leverage collaborations and partnership to make sure that you join forces that would enhance effective implementation of the project. Do research, of course, of funding opportunities aligning with your goals, and adapt proposal, ensure sustainability, be innovative at every stage, reflecting all the areas I've mentioned. Then be innovative at every stage and build partnership and engage stakeholders. Thank you very much for listening.
Thank you so much, Mr. Eric, for that insightful presentation. My biggest takeaway was how we can gain funding as youth. You've told us how we can find the right funders. You've told us about building partnership and tailoring our proposals to funders' needs, as well as demonstrating sustainability of the project. Thank you so much once again. For our participants, in case you have any questions, kindly type in the chat box or raise your hand and you'll be given the floor to speak. Maxwell, the floor is yours. You can ask your question.
Yes, thank you very much. I think mine is not probably a question. It's just a recommendation that I also want to contribute to the presenter in the area of the monitoring and evaluation, because I am an expert also in that area. And one of the key things that we have recognized is that most people present proposals or strategic plans, beautiful as they are, so innovative. But at the end of the day, because they do not understand the monitoring and evaluation component of it, such proposals are turned down. So I will rather advise that anytime that anybody has an intention to put up a proposal, the person should rather outsource the component of the M&E to an M&E expert, or just get an M&E person on board, so that that person will be able to identify and then develop a monitoring and evaluation plan. Because without it, funders are not ready to give you their funds. Because remember that he made an emphasis that one of the key components is accountability. And how do you become accountable? By looking at how your systems are being monitored and how they will be evaluated. If you are not able to spell all these things out, then your beautiful innovative concept for funding will not be approved. Thank you very much.
Thank you very much, Maxwell, for your contribution.
Mr. Eric, I can see in the chat that that George is requesting for the slides and your email. If you could kindly share with us.
Yes, I'll even share the slides with the organizers, and then they will circulate, and I'll provide you with my email address.
Thank you so much. And thank you once again for the very insightful presentation. You've given us a lot to think about. Thank you.
Thank you so much.
Kindly, if any of the participants have a question, please do not shy away. Raise your hand or type in the chat box.
Okay, so in the absence of any other questions, we'll move right into it. I've learned so much from the first two sessions, and I promise the next few sessions we have next are going to be very insightful. Up next, we have a speaker. She's a consultant in research management, science education, and outreach. She's currently based in Hyderabad in
Hyderabad.
India. Hyderabad in India. Okay, thank you. She's a co-founder and co-leader of Superheroes Against Superbugs, an initiative that engages young minds in India to combat antimicrobial resistance through education, creativity, and awareness, inspiring the next generation to contribute to global health. This initiative has gained international recognition, being highlighted at the UN's Call to Action on AMR meeting in Ghana by the World Health Organization during WOW Week in 2018. In her current role, she serves as Associate Director of Research at LV Prasad Eye Institute, Hyderabad, with a PhD in molecular biology from the University of Sheffield, UK, and postdoc from University of Oxford, UK. She previously served as grants manager at the DBT, or Wellcome Trust India Alliance, a funding initiative. In 2022, she was honored as Young Emerging Leader by the US Department of State for their International Visitors Leadership Program on Biomedical Innovation and Entrepreneurship. She remains deeply passionate about advancing science, education, and outreach. Ladies and gentlemen, I present to you Dr. Punari Gotipati. You're welcome, Doc, and it's we can't wait to learn from all you have for us this afternoon. Thank you.
Thank you. Thank you so much for that uh, uh, introduction. And thank you also for the invitation to speak at this event. Always a pleasure to interact with the young people from Africa, and I consider myself fortunate to have this opportunity year after year through forums like this. So thank you again. So let me quickly share my presentation. Okay. Can you see the full screen, or is it showing up as a... Yeah.
Yes, that we can see it.
Okay, yeah. Thank you. So the topic I was given today is to talk about uh, tailoring AMR communications to local communities. So what I'm going to be doing in the next 20 minutes or so is take you through our experiences at this initiative called Superheroes Against Superbugs, on how we interact with different stakeholders and different communities, specifically on AMR. So Superheroes Against Superbugs is a youth-focused educational and public engagement initiative. We started off this work in 2000. We started this work in 2018, and we work to raise awareness and promote public and policy action on AMR in India. And these are our main objectives. We develop innovative and engaging approaches to to simplify AMR and to make people's understanding of AMR better. We also, like I said, work with young people to advocate for AMR, and our idea is to make them create these change agents out of these young people that we interact with. We also build diverse partnerships, and through these partnerships, we try to elevate the awareness and also inspire proactive AMR measures among youth and the public. And finally, we try to mobilize different stakeholders, students, educators, health professionals, media, industry, so on and so forth, to influence key actions on decisions on AMR. So these are the different audience that we work with through our various initiatives. Children and young people remain our primary focus. So these include school students. These also include undergraduate and postgraduate students from the sciences background, from medical students, pharmacy students. And the reason why we primarily work with young people is because we believe that, that they are capable of influencing behaviors around them and bringing about transformative change when they're equipped with the right information and tools. And we feel like issues like AMR, which is really central to the well-being of young people who are going to become the global citizens of tomorrow, really need young people only to advocate for. And we always say that there are a lot of parallels between climate change and AMR. And like with climate change, which is again really central to their future and well-being, AMR also, we feel, requires young people to champion the cause. So in addition to working with these stakeholders, we also routinely interact with the public, and we also try to engage with media and policymakers on different AMR related topics. The reason why we work with all of these different people is because our call to action at SAS is that each one of us has a role to play in tackling AMR, and that everybody needs to come together to tackle this issue. And just a few statistics. Our primary modus operandi is workshops. That is how we engage with school students. That is how we engage with undergraduate and postgraduate students. But we also conduct various other public engagement initiatives for general public. I'll take you through some of these in the next few slides. And as you can see, we also kind of work across the country. We are primarily focused in Hyderabad, which is in the south part of India, and in New Delhi, which is in the north part of India. That is where our team, which is again, you will see later, is just 4 people, but this is where we are primarily based. But thanks to our program associates and thanks to many different volunteers, we are actually able to take our initiative to many different parts of the country. And these are not always necessarily tier 1 countries. These are also like, remote areas, tier 2 towns, and so on and so forth. Okay, so coming to the main topic of discussion today, ever since we started working on AMR to even now, like, after so many years also, we feel we still feel that talking about AMR is very difficult. And it is primarily because of, these following reasons. There are a number of challenges here, and the most important one, I think, is the complexity of the issue itself, because it is complex on so many different fronts. There are so many different technical concepts to understand. The science itself is so complex, and there are also so many there are multiple drivers to the problem. It causes different socioeconomic challenges. It's not just complex scientifically, but it is also complex on many different fronts. And therefore, it is very difficult to talk to different people about it. And secondly, the relatability, right? It seems like such an abstract problem. You talk about conditions like, I don't know, like HIV or diabetes or cancer. They're much more relatable because you actually know people who suffer with it. You kind of see survivors. You kind of see, all of these openly discussed. But AMR is something that you don't really. It's not like you hear of patients suffering with, we know the statistics. We know a lot of people suffer with drug-resistant infections, but on a regular daily conversations, on a day-to-day basis, it is not something that we hear very often, and therefore it seems like a very abstract problem. And because of the lack of this relatability, it also feels like too distant a problem, because there is that personal connect that is missing. Again, because I'm sure all of us know people who have suffered with drug resistant infections, but then again, ask anybody about cancer patients and they'll be able to name them. Whereas, with this, it's not as simple, right? Because it's not just one disease. It is like a group of so many different diseases where drugs stop working, and therefore it becomes a little that personal connect most of the time is missing. And also, like I said, there are so many parallels with climate change, and another parallel is that it seems like too big a problem. There are so many different contributors. There is, so many different drivers. It's such a big problem. What can an individual do? More often than not, it may feel like it is something that that is beyond a person. So these are all the different things that we deal with on a regular basis, especially when we are talking to, public about the problem of AMR. And so we kind of devised a strategy to tackle this. And the way we do that is to combine novel science education tools with different innovative public engagement approaches. So we kind of employ both in most of our workshops and most of our activities. And through our education, we inform young people about AMR, and we use hands-on activities and fun games to talk to them about this problem. And we always employ a fun and creative approach so that the complex issue becomes more comprehensible. And we, more often than not, all of our educational endeavors are through these games and fun activities rather than didactic lectures. And all of our educational resources are, freely available for anyone to use. And then our engagement approach is that we actually partner with the participants in our workshops to come up with these engagement resources. We always partner with young people to raise awareness, and we use innovative communication and engagement methods, some of which I will talk to you in the next few slides. And we also always focus on impactful messaging. What is the key message that you're going to give out on any interaction you have with any of the people that you're going to be talking to about AMR? And again, like our educational resources, our engagement resources are also available for others to use, but more often than not, because we collaborate with the workshop participants, we actually provide these engagement resources to our workshop participants then to go and raise further awareness on the issue using the material that they create themselves. Yeah, so like I said, some of our educational tools, we have informational talks, we have group hands-on activities. And again, when I say talks, these are not lectures that you will hear in a lecture, in a usual educational setup. We also have group hands-on activities and games. We have discussions with experts, and we also use our own animations and videos as well as those that are available freely to sort of break down the complex messages into simpler, easy to consume key messages. And so when I talk about games, there are many different kinds of things that we use, and depending upon the audience that we are interacting with, we kind of sort of tailor our games and activities also for that particular group of audience. For example, the kind of educational resources that we use for the school students is very different from the kind of educational resources that we use for our, of course, for the medical students or the pharmacy students. And what we try to understand, what we try to do is basically understand the setup that they come from, what their starting knowledge is, how much do they know about anything really about, I mean, with school students, they may not even know about microorganisms or infections, right? And same with the medical, I mean, with the medical students and pharmacy students, of course, they would have all of that knowledge, but what are they starting off with on which we can sort of build and start talking about AMR, because AMR currently, unfortunately, is not part of the educational curriculum in schools or medical colleges or pharmacy colleges. So we kind of try to identify the gaps in these medical different curriculums, and we kind of try to fill in those gaps using our educational approaches. So you can see some of these here, and most of our educational approaches also use like a very sort of they're not resource intensive at all. The activities that we come up with are very cost effective. We always try to identify easily available materials that people can use in any part of the country, even in the remote areas where, or even places where you don't have proper facilities, and places like that also these games and educational resources can be used. And we also place a lot of emphasis on role play and drama and theater. Again, you can see two such examples here. This was from one of the medical workshops that we've done, and this is from a school workshop. And again, what you see here is actually like a proper medical theater, where you have like a live case study happening, and then you kind of pause the case study once in a while, and then the audience sort of engage and interact on, how the treatment should be taken forward, etc. Of course, with school students, it's much more dumbed down, and it's like bringing their real life scenarios into the drama for them. And we also use a lot of competitions. We also use a lot of case studies and other interactive ways to engage with our audience. We also give them a platform to interact with various stakeholders like scientists and doctors and also other stakeholders. And this is because for young people especially, it is important for them to understand how they need to contribute to solving the problem, but also what are some of the other things that people are doing to get a well-rounded approach to the problem of AMR, to understand all of the different aspects of the problem of AMR. And so we actually bring doctors, we bring scientists, and we get them to interact with these young people and other stakeholders also. For example, this is a panel discussion that we recently conducted at the Global South Conference on antimicrobial resistance. And here we got like patient advocates, we got people patients that suffered with, infectious diseases. We got media, we got people from pharmacy federations, and we got science communicators. All of them come together on one platform to sort of interact with the audience and engage with the audience and sort of, bring their different perspectives on what can be done to tackle the problem of AMR. So these are some of the things that we do. And another thing that we always do, no matter whom we are trying to engage with, is soliciting their own experiences through various exercises. For example, with school students, what we do is we give them an exercise where they have to go and talk to their parents about when was the last time they used an antibiotic, or any medicine for that matter. Can they find out if that is an antibiotic? How did they get it? Did they actually just buy it over the pharmacy, or did the doctor prescribe them? Just to make them understand that this is not a distant problem. All of us are actually contributing to the problem. This is happening, in your household as well as in my household. Another exercise we give them is sending them off to a local pharmacy and, with their parents, of course, and then asking them to buy an antibiotic randomly to see whether their local pharmacies will actually give them the antibiotic without doctor's prescription. So all of these different exercises just to solicit their own experiences and make the problem a bit more relatable and a bit more personal for them. And all of these lesson plans and activities are available on our website. These are some of the animation videos that we have come up with ourselves. And here also we kind of try to use a little bit of fun. For example, this animation, the central character is the antibiotic itself. And in this animation, the central character is a superbug. And we also come up with these other educational material from time to time. And when it comes to engagement, we place a lot of importance and focus on creative, visual, and performing arts. And we use these also, like I'll give you some examples, but we also conduct a lot of community events and collaborative dialogues. Like you saw, the panel discussion was one such thing. And we also use social media quite actively to reach out to our audience, especially the general public. I think I don't have to tell you much about the power of art and storytelling, because in my recent interactions, I find that storytelling is very, very integral to the African way of living. I see that is used very extensively in a lot of health communication in Africa. We do the same in India also, because there is a lot of power, right? Because storytelling, through stories, we can actually go beyond the statistics, we can go beyond the facts and figures and actually connect with them, catch their attention, make it more relatable to them, and also simplify the messages in a way that, they are able to absorb and they're able to relate to. And of course, art has the unique capability of, creating both a sensory and a cognitive experience. So you're not only thinking about the problem, but you're also actually feeling about the problem. And therefore, it is very powerful to communicate valuable messages across cultures and political divides. And art, when done the right way, I think can also provoke people to stop, gaze, and reflect on the messages. So we use a lot of these. And like I mentioned already, we actually co-create these resources with our participants, because we are trying to utilize the inherent creativity that young people have. And therefore, that is why we partner with them. And because these are, the participants co-create them, these are like their unique messages to the world on AMR. And therefore, there's also a sense of ownership, because it's like, their thought put in the form of an art. And when these young people then take these art to their spheres of influence and to their communities, then there's also that connection, because the audience know the creator of the art, and therefore there's also that connection that happens between the audience and the creator. We also routinely collaborate with artists and use different mediums, and this serves a double purpose of involving artists in the dialogue on AMR, as well as using their creative inputs in talking about the issue. So grassroots comics are one of the most, I think, our signature creative medium and most popular of our work. And we do this in collaboration with Mr. Sharad Sharma from World Comics India, who actually came up with this particular medium. And this is just basically like, you talk to them in a 3-day workshop, for example, 2 days of education, you give them all of the information they need about AMR. And on the final day, we ask these kids to come up with stories. And then Mr. Sharad Sharma works with these kids in turning each of their stories into a 4-panel comic. And these are black and white, just done with a pen and a paper. And that is why these are very easily reproduced. They're very cost effective also. But then they become a very important communication tool, because this is their individual story on the problem of AMR. And it's a very powerful medium of expression, because very serious issues can be expressed in a very uniquely creative way. And comics, of course, appeal to children and adults alike. And it makes the easy to connect with the issue. So when when we're talking about tailoring communication to local communities, right? I think these actually are a very clear example of that. So depending upon where our workshop participants are from, we see very, very clear distinction in the kind of messages that they want to give out through these comics, right? For example, in urban settings where healthcare is freely available, many of the kids that we work with actually choose the topics of misuse and overuse as as the areas that they want to make their comics on. These are some of the examples. But when you go to farming communities, when you go to children from these communities, and you see that they want to make comics on such related topics, for example, about a poultry farm here, or about using antibiotics in veterinary care, or here in aquaculture. And we also have done few workshops in northern part of the country where there is a pharmaceutical company, because as you know, India is called the pharmacy of the world. So we have a lot of pharmaceutical companies, a lot of pharmaceutical waste being dumped into our rivers and water bodies. And when we worked with kids in villages around these areas, and most of their communication messages and their comics were around dumping antibiotics into rivers and things like that. So they had a very, very powerful messages to give to these pharmaceutical companies. And similarly, when we work with people from lesser socioeconomic backgrounds where healthcare is not that easily accessible, then we see that their messaging also changes. They want to talk, they focus more on hygiene and sanitation and preventing infections rather than actually misuse and overuse of antibiotics. So I think this is such a fantastic example of why it is so important to tailor the message to the audience that you're talking to, because their lived experiences, their personal experiences, where they come from, what their background is, all of that plays a role in what they relate to with the problem. Even though the problem of AMR is the same for everybody, the way different people relate to the problem is so very different. And that is why it is very important to tailor your messaging. And very quickly, I also want to talk a little bit about other mediums that we use. We've recently started using street art and murals to talk about AMR. This is one of the murals, mobile mural, that we created in Hyderabad, and this is a mural we created in a very central location in New Delhi, and this is a permanent mural. And both of these are again co-created by young people. So the idea for what the mural should say and all of those things actually came from the people that participated in our workshops. And then we work with street artists in turning that into a mural. And again, the artwork is also done by both the artists and the young people themselves. And these murals actually act as a collective thought spaces, because they make people, these vibrant colors, they make people stop, take a pause, stare, and they act as collective thought spaces to create dialogue and raise awareness. And we also do very simple activities. Of course, making a mural is a big process, but we also do other simple things like, wherever we go, we interact, we have this small activity where we ask them to talk to them about AMR and tell them, hey, why don't you create your own unique message on AMR on a small fridge magnet? And then they do that. And then this is something that they take home and put it on their fridge. And then this is like a daily reminder for them on AMR, and also a good conversation starter, because people, when they visit home, they see this fridge magnet and they're like, hey, that looks interesting. What is that? And then they have an opportunity to then talk about AMR. So And we also kind of work. I mean, this is a workshop where we kind of worked with writers, and then they came up with like fictional stories around AMR. They came up with poems on AMR. And this is a street theater group that worked with us, and they came up with street art, a street theater, to talk about AMR. And last VAV, we did something very interesting. I mean, many of you might know that India, Bollywood and cinema is such a big thing, right? I mean, it's very, very popular. So we thought we'll take advantage of that, and we collaborated with this a group called Gangs of Cinepur. And then we came up with this content where we looked at different Indian films that talk about microbial diseases, and we sort of used that to to identify what disease they're talking about, what are the bacteria, what kind of what are the different antibiotics that can be used, and just to raise awareness on all of these things through the medium of cinema. And we also, like I said, social media is one of our mediums as well. And we come up with lots of different educational blogs. And we also come up regularly share research and news through our social media. Again, in a very interactive manner. We also come up with memes and riddles, again, different ways to engage and that keep that attention span going for our audience on our social media. So finally, I hope I'm not exceeding my time. So what are the learnings from all of these different engagements, and what are the challenges that we should still be thinking about? So effectively breaking down complex information by using simple non-technical terms while talking about AMR is very important. No matter, even when we talk to medical students, we need to do this. And also always using interactive content, hands-on activities, narratives, visual tools. They also help unpack concepts. And partnering with the participants and co-creating makes the issue more relatable and encourages the audience to take ownership of the issue. But one size fits all approach does not work. We need targeted messages. We need engagement strategy that is based on social, economic, and cultural context. What are some of the challenges? I mean, we talked about communication challenges initially, but also when you're interacting, some of the other things that we need to keep in mind is to maintain that balance between scientific accuracy versus creative freedom. Too much information versus oversimplifying. It never, because it's never a good idea to, dump them with too much information. Just give them enough information to help them make sense of the problem. Don't talk to them about everything. And it's also very, very important to humanize AMR, making its impact relatable and tangible to the participants, talking about patient stories, going beyond those numbers and facts and statistics is very important for people to connect with the problem. And something that I've not really talked about much, but just like in Africa, in India, we have a lot of vernacular languages, and it is important that we make the content in these languages in addition to especially when you're dealing with local communities. You need to talk to them in their language. You need to make whatever content that you develop in their languages. And a previous one of the after the previous talk, one of the participants mentioned about the importance of evaluation. And it is the same with outreach activities. It is the same with these awareness activities also. Evaluation is very important. But then, it's very difficult also to come up with proper evaluation for creative mediums. It has its own challenges. And also behavioral change is not that easy to measure as well, but it's still important. And you can come up with some quantitative and qualitative metrics depending on the, your methodology to kind of come up with some sort of an evaluation plan. Definitely, because that will help you understand whether the strategy that you have chosen is working or not for that particular context, for that particular community. And finally, what I also want to say is, in all of our engagements, we always leave participants with a call to action, because it is, after listening to all of this, it is important for them to know that there is something that they can do personally to contribute to this problem. So identify those call to action messages for each of the groups that you interact with, and leave them with that message, with that key takeaway. And these call to action messages need to be very clear, they need to be accessible, and they need to be something that encourages immediate action. So they feel like, then that momentum, there is something that they can do. And you also have to emphasize on the urgency for action, that it is not a problem in future, it is happening right now, we need to act on it right now. And some of the things that we use in our engagements are concentrating on hand hygiene, concentrating on community hygiene and sanitation, no over-the-counter purchase of antibiotics, and then completing the course and not sharing. These are some of the messages that we always try to give out depending on whom we are talking to. And finally, this is our team. All of us are scientists turned science communicators and public engagement, interested in public engagement, interested in science education. And this is something that we do out of our passion. We all have our day jobs, which are different from Superheroes Against Superbugs, but we're very, very passionate about this. And thanks to some of our fellows who have taken our work to different places, people that collaborate with us, the schools, the colleges. And what you see here is again a blog series where we try to sort of champion the people that are working behind the scenes on AMR. There's like a policy advocate, there is a scientist, there is a agricultural scientist, this is a patient advocate, this is a clinical microbiologist, and this is an infection disease specialist. So we kind of try to bring again through, we kind of through these articles, we try to bring their stories to our audience. So just wanted to mention that here. And thanks also to our many volunteers, for our funders and supporters, our institutional partners and collaborators. And yeah, thank you. And these are our social media handles. And if any of you want to get in touch with us, please feel free to do so. Thank you so much. I'm
Thank you
happy
so
to
much.
take questions.
Yes, please. Thank you so much, Dr. Ponari. That has been an insightful presentation. Learning how to communicate the present prevalence of antimicrobial resistance in our communities. And I've taken home a lot, and I'm sure the audience have too. Please, if you do have any question, you could raise your hand or type it in the chat box. I think we have one question from Faith. Faith, you can go ahead.
Thank you. My name is Faith from Kenya, and I
Hi.
have just two questions for you. So my first question is, you'd find that in the experience in Kenya where we have lots of watch antibiotics, the antibiotics that are more likely to cause resistance, we have more of watch antibiotics being more common in the market compared to the access antibiotics as the AWARE guidelines for WHO outlines. So you'd find that as a pharmacist, you're aware of the access antibiotics, which aren't as common within the in Kenya, but they're available. So you prescribe to a patient the access antibiotics, which is supposed to prescribe to them, but the patient tells you that no, for one reason or another, they're more comfortable having the watch antibiotics because it's what they're used to, it's what they've been seeing all through. So how would you, in that case, how would you spread awareness to such a patient to know how dangerous the drug that they're used to is in like how they respond to treatments later in the future? What's the most effective way? And my second question is, now you've given me very many insightful and creative ways of spreading awareness about AMR to the public. So in case of a situation like a walk where Students Association has organized for a walk to raise awareness on AMR, what do you think would be the best and most effective way to deliver such a precise and impactful message on AMR? Because the walk usually targets people who are in their day-to-day lives. There may be people who are vending in the marketplaces. Mostly we target people who are bystanders or people in the public transport system. So what do you suggest would be the best way to pass the message of AMR awareness in such a situation? Thank you.
Okay, yeah. Thank you, Faith. So I think I'll take the first question first, which is about the problem of, I mean, how to communicate to the patient about the importance of not using the watch category of medicines, and what pharmacists can do. Is that the question? How can pharmacists raise this awareness? Is that what you're saying, or anybody, how can anybody talk about patients about this problem? Yes, okay. So in our so we kind of face a similar problem in India also, because in India again we also don't have very clear regulations. I mean, of course there are regulations, but they're not really implemented that effectively in India also. And unfortunately, many of the pharmacists themselves also are not aware of many of these things, because not all, I mean, many of the pharmacies actually may not even have educated pharmacists. They're considered almost like local stores sometimes, and there is just a shopkeeper who's selling medicines. I mean, I'm not saying all pharmacies, but there are places like that also. So in what we do in our, like I said, we also recently conducted a series of workshops for pharmacy students, and we were also kind of sort of discussing about such issues and how pharmacists need to raise awareness and things like that. And what we realized is that uh, when we talk to pharmacists, especially, most of our engagement is around communicating with patients. With medical students, it's about prescribing antibiotics, antibiotic policy, stewardship, and things like that. But in our workshops for pharmacists specifically, we actually engage with them on these challenges of communicating in their local context, and how they should be communicating, how they should be talking to patients about these things. And it's usually a dialogue, because we are not pharmacists, right? They are the pharmacists. So usually we kind of ask some important questions, and we kind of let them reflect on how they would then take this message forward, how would they put it into context, how would they then talk to the patients about this. And in that way we kind of find a way for them to talk about the problem. So I would say this has to be like a, you can't just give them of course, we also came up with some resources, like we came up with this poster that they can put up in pharmacies, where this is the poster on one side has messages for pharmacists themselves on good practices, and on the second side of the poster there are messages for the patients. So the idea was that, again, when you're talking to the patient, you're not like, it's not pointing fingers at anybody. It's again sort of, both the messages are there. So you're kind of creating a dialogue again between the patient and the pharmacist. So these are, I think, some of the approaches that you can also do. Like, you can come up with a poster that specifically talks about the AWARE classification and about the watch medicines versus the reserve medicines, and also explain to them, obviously have to talk to them a little bit about AMR, and then explain to them why they are reserve medications and what are the disadvantages of overusing reserve medications, and what is then going to, how is that going to impact them, their families. And it always has to be, I mean, this is something that we hear from clinicians also, that it always has to be very personal. It cannot be that so many people around the world are dying. It has to be something personal about how this problem is going to impact them and their families and their children, and that, I believe, has more impact than talking about statistics and things like that. I hope that answered your question, Faith. And I kind of forgot your second question. So, but I think we have other people asking questions also, so maybe we could.
Yes, please, but because of the time, we are behind
Okay.
schedule, so we'll take the questions later. Thank you so much, Dr. Panari. That has been an insightful presentation, and I'm sure we are going to implement them even in IPSF and in our individual communities. Thank you so much. That was tailoring AMR communication to our local communities. We move on to the next session.
Thank you.
Thank
Thank you so much for the opportunity.
Welcome. The next session is on AMR and oral health, addressing antibiotics resistance in dentistry. And we have our speaker already here in our midst. She's an academic general dental practitioner and NIHR clinical lecturer at University of Manchester and GDP in South Cumbria. In 2020, her doctoral research won the Antibiotic Guardian Research Award for its focus on reducing antibiotic prescribing during urgent dental appointments. She is the lead author of the FDI World Dental Federation's 2020 white paper on antibiotics in dentistry and lead educator of the BSAC or FDI MOOC, tackling antibiotic resistance. What should dental teams do? She is also an honorary consultant in the NHS Office of the Chief Dental Officer, England, and advisor to the National Institute for Health and Care Excellence and British National Formulary. Dr. Wendy graduated in microbiology from University of Warwick. She gained her BDS from University of Liverpool and her PhD from University of Leeds. Ladies and gentlemen, Dr. Wendy Thompson. You're welcome, Doc.
Thank you very much. Can you hear me okay?
Yes, please, I can.
Right, I just need to share my slides. I won't be a moment. Marvelous. Can you see the slides there as well?
Yes, please, we can.
Thank you very much for inviting me. It's an absolute pleasure to talk to you all today about AMR and oral health. As already introduced, I'm Dr. Wendy Thompson. I'm a clinical senior lecturer in primary dental care, and I'm chair of the World Dental Federation, so FDI World Dental Federation's task team on preventing AMR infections, and I'm vice chair of the science committee. So question for you all. I'm not going to ask you to write it into the chat, but I guess we could have done, I should have had one of those interactive things. What percentage of antibiotics globally do you think are for dental reasons? Some of you might know, some of you might not know. But the answer is about 10%. A bit more in some countries, a bit less in others, but it's around 10%. And before antibiotics and before modern dentistry, people regularly died from dental infections. And this infographic is from the British Medical Journal a few years ago now. And the size of the gravestones shows you the number of people dying in 17th century London from before antibiotics, many years before antibiotics, shows a number of people dying from dental infections in 17th century London. So you can see that the largest gravestone there is consumption, which we know as TB nowadays, and cough. And then you have people dying from plague, and because they're old and young and they have a fever. And then the sixth most common reason was teeth and worms. And the reason it's got worms alongside teeth is because they used to think that tooth decay was caused by a worm. So the sixth most common reason that people died was because they had a dental problem. And we don't really think about people dying from dental problems because we've got antibiotics and because we've got modern dentistry. But we need to remember that as antibiotics stop working as well, and as access to dentistry can be really quite poor in some places, we need to think about the impact on people's dental health, because people forget that the mouth is the access point to the body. It's because that's done by dentists, it's not done by doctors, and therefore it seems there's something completely different. But actually, your mouth is the gateway to you, and it's really important to remember oral health as part of overall health. So antibiotics are life-saving drugs, and I'm sure that you know within lots of different ways that antibiotics save lives, but you probably don't really think about them saving lives because of dental problems. But you can see two pictures here, which if they arrived in my primary care dental practice, I would be very scared and I would send them straight to hospital in an ambulance. On the left-hand side, you have a periorbital cellulitis that is an infection that's come from probably her canine tooth, an upper canine tooth, and there's a risk of that spreading back through the angular vein, which is at the back of the eye. There's no valves on the angular vein, and straight into the cavernous sinus, and people get cavernous sinus abscess and die from that if it isn't sorted out. And the other one there is Ludwig's angina, and that's when it's often a lower wisdom tooth, although it can be other teeth as well, that gets infected, and the infection spreads through the fascial planes in the floor of the mouth, and it goes on both sides of the neck and occludes the airway. And again, that can be very quickly life-threatening. People die from that. So they need antibiotics. These two patients need antibiotics, but they also need a dental procedure to lance the boil, if you like, to get rid of the infection. Because dentists are dental surgeons, actually they would be seen by oral surgeons and maxillofacial surgeons in hospital, these guys. But if it was a slightly less severe infection, dentists, dental surgeons would do a procedure. Antibiotics are not usually needed, but when people need antibiotics, they need them to work because they're life-saving. And if antibiotics don't work when there's a life-threatening infection there, then that's not great. Dental infections also can easily become sepsis because the head and neck has a very high blood flow, and dental infections are very close to that very high blood flow, and so sepsis can easily set in. So as I said, procedures, not prescriptions, are the quickest fix for toothache. So you can see here on the left-hand side, this is a tooth that I took out with a dental abscess on the end. That was on a Sunday morning. I was working on an emergency clinic. And you can see the abscess there because it's a little round thing at the end of the root of the tooth. Can you get your orientation? On the right-hand side, there is a filling in the top of the tooth. And then you've got the reddy orange bit, which is the root of the tooth. It's about twice as long as the crown. And then you've got a little round bit at the end that is the abscess. And once that tooth's taken out, there's no abscess left in there. And so there's no point of giving antibiotics. They don't need antibiotics. The infection's all disappeared. So that's one way of getting rid of the infection. The other is this one, top right-hand side, where you can see the teeth in the middle. It's got a needle being injected into it. It's not really injected, but it's being used to wash out where the nerve and the blood supply of the tooth used to be. You can see down at the bottom, that is a picture of the nerve. It's like a little file that we use for taking the nerve out of a very angry tooth. And that red squiggly bit is the nerve. And on the tooth at the top, so they've had the nerve taken out, it's being washed out, and then we'll put a nice dressing on the inside of that and patch it back up again, and the patient will be very much happier, not in pain anymore. And again, they didn't need antibiotics because there wasn't an infection there, it was an inflammation. And just like if someone sprained their ankle, if someone sprained their ankle and came to you and said, please, can I have antibiotics? You would say, don't be silly. You don't need antibiotics. You sprained your ankle. And it's the same thing with toothache. We should be very often saying, don't be silly. You don't need antibiotics. You've got an inflammation of your pulp. We need to sort out that. Sometimes that, if it isn't sorted out, turns into an infection. So we do need to diagnose properly to know what the difference is between an inflammation and an infection. But dentists have access to all the chairside diagnostic tools that they need to diagnose what's causing the toothache and whether, and they've got all of the tools, the drills and the extraction forceps and the local anesthetic to get on and do the treatment there and then. You don't need to have an antibiotic to clear up any infection. You don't need an infection cleared up before you do the treatment. If someone's infection is becoming systemic and it's becoming a real big problem, then they need antibiotics and they need them to work. But most of the time, you need to do a procedure to sort them out, and antibiotics aren't necessary. With access to dental procedures, antibiotics are usually unnecessary and inappropriate. And that's key, really, the access to dental procedures, because in lots of parts of the world, people don't have access to dental procedures, and that's a real problem. And one of the FDI calls is for universal access to oral health care. You will have heard probably about calls through the World Health Organization and the United Nations for access to healthcare for all. And we add the word oral healthcare for all in there because without oral health, you don't have health. The World Health Organization has an antibiotic book, and within that antibiotic book, it has an oral and dental infections chapter, which shares a lot of the things I've just been saying there. So, for example, you don't need any antibiotics for dental caries, which is tooth decay, because there's no infection there. You don't need antibiotics for toothache, which is coming from the nerve. That's the kind of 10 out of 10. A patient's coming in and saying, oh, I didn't sleep last night. I'm in a lot of pain. That is an inflammation type toothache. They don't need an antibiotic. It's not going to work. It's an inflammation that's causing that. What they need is the nerve taking out or the tooth taking out. Even anti-inflammatories don't really work very well. And actually thinking about analgesics, ibuprofen and paracetamol together are the best analgesics you can have for toothache. They don't work as well as taking the tooth out or as taking the nerve out, but they're better than anything else. Codeine really doesn't work very well for toothache because of the way the different kinds of nerves, these are cranial nerves in the head and neck. They're not from the peripheral nervous system. The dry socket is if you've taken a tooth out and it's very slow in healing, it's an inflammation of the bone. Its proper name is alveolar osteitis, and anything ending itis is an inflammation, not an infection. Periodontal disease, again, is an inflammatory disease. It may be stimulated by bacteria, but that's actually your microbiome. That's your normal microbes. They're not an infection. They are just part of you. So the antibiotics don't cure periodontal disease. You need to have treatment there to clear up, teach people how to do oral hygiene, and they need to keep on top of that through their excellent home care. Antibiotics may be needed if they've got an infection that's become systemic as a result of periodontal disease, but that doesn't happen that often. Viral and fungal infections, as you know, don't need antibiotics. We do see viral and fungal infections, cold sores or oral thrush, for example, but we don't prescribe anywhere near as many viral or antivirals or antifungals as we do antibiotics. And traumatic injuries and tumours. Again, when you're diagnosing toothache, you always need to have half an eye on whether it could actually be an oral cancer causing the problem. Thinking about if someone's a smoker, for example, or chewing betel nut or that kind of thing, we need to be thinking about what's going on for them. Right. Within the antibiotic book, there are 4 clinical presentations which might require antibiotics. They are a dental abscess, they're a pericoronitis, they're necrotizing periodontal disease, and a condition called noma, which I suspect some of you may have heard of, but I also suspect lots of you won't. So dental abscess is I suspect a lot of you will think that what I described as toothache before is an abscess. It isn't. A dental abscess is where there is natural frank infection there with a swelling. And if that swelling goes beyond a certain point to become systemic, then that's when it might need antibiotics. It also needs a procedure, but it might need antibiotics. Pericoronitis is that wisdom tooth that's, I was saying to you, most of the time is an inflammation, but sometimes goes beyond being just an inflammation and gets to the point of causing an infection. That, do you remember I showed you Ludwig's angina? That would need an antibiotic. And then you have necrotizing periodontal disease. So that you might have heard that called acute necrotizing ulcerative gingivitis. That was one of the old names for it. Again, it usually just needs a lot of cleaning up and the smell of someone walking in with necrotizing periodontal disease is really bad. And it's often when they are run down, stressed, their immune systems aren't working quite well. But they need to be really excellent home care. The dentist needs to be giving them excellent healthcare as well, but sometimes they need antibiotics for it. And then noma. Noma is known as a disease of extreme poverty. It tends to happen in extremely resource limited places, and there used to be a part of sub-Saharan Africa called the Noma Belt, and Nigeria has so many cases of Noma that the government recognized it and set up a hospital called Sokoto Hospital in Nigeria, which is for Noma specifically. And Noma is I will talk to you more about Noma on another slide. Noma is a severe disease, and it is completely treatable if detected and managed early. Okay. And it starts like this, and this is necrotizing ulcerative gingivitis. You can see that the gums are looking really, really swollen, and they're not looking very happy. That's not just you haven't cleaned your teeth for a couple of days. There's something more severe, more systemic going on with that. And if you're working in these very resource limited settings and you see that, you need to refer them into a hospital straight away, and they need to have antibiotics, but they also need to have nutrition programs. and excellent oral hygiene as well. Antibiotics for Noma are essential. Without antibiotics, Noma kills 90% within 2 weeks. It's mostly in sub-Saharan Africa, as I've said, and most of them are children aged 2 to 6. That's the age when children are starting to get their baby teeth coming through. And that's the kind of lesion that we're talking about, because this necrotizing disease doesn't just stay around the teeth. It then eats away flesh and bone. And as I say, kills 90% within 2 weeks. And the 10% who survive have a lifetime of follow-up care to keep them fit and well. Dental antibiotic overuse and misuse is a problem. Think about 10% of all antibiotics across human healthcare being for dental reasons. In the UK, a study found that more than 80% are unnecessary, and that little asterisk you'll see at the bottom, it comes up later on. Little asterisk means that used not in accordance with local guidelines. So in the UK, we have very detailed antibiotic guidelines, and 80% were not in accordance with our guidelines. In the UK, almost all of our dental antibiotic prescribing is therapeutic. And so of the 10%, which are 10% nationally of antibiotics which are for dental conditions, around 80% are unnecessary. In the US, a study found that around 80% were unnecessary, and that was mostly related to their prophylactic dental antibiotics, because in the US, they have very different guidelines to in the UK, and they prescribe antibiotics a lot more than we do. But again, 80% of those were for prophylactic reasons, for giving antibiotics when you take a tooth out, for example, just in case they might have prosthetic joints on their heart valves on their in the local area where you took the tooth out from, or their dental implant might not take. The guidelines around those areas are very, very, very tightly defined, but around 80% were unnecessary use. In Ghana, a study that we did there found that more than 90% were unnecessary. So what would the figure be in your own country? And the answer is we probably don't know, because the studies I've presented here are the key studies that I know of. There will have probably been studies done in some other countries, but I've not noticed any go through. Lots of students will ask what sorts of antibiotics are prescribed by dentists, but very few of them actually talk about whether they were necessary or unnecessary, because that's quite a detailed project that needs to be done to find that out. It isn't just all dental antibiotics are necessary or all dental antibiotics are unnecessary. As you've heard me say, they might be necessary if they've gone beyond a certain point. So a dental abscess might need antibiotics if it's become systemic, if the symptoms have become systemic, but actually most of the time they just need the tooth taking out. So dental antibiotic stewardship in sub-Saharan Africa is a subject close to my heart. We have a project that I'm leading there in Ghana and Uganda at the moment. It's about developing evidence-based ways to reduce unnecessary antibiotic prescribing by dental teams. We're just starting that project now. We have got the ethics applications about to be submitted, and we will be hopefully collecting data in January, February time. So if any of you are based in Ghana and Uganda and know any dental teams who want to get involved, then please do let us know. I am the chair of the FDI World Dental Federation's antibiotic stewardship group. What do we call it? Preventing AMR and Infections group. And we produced, the first thing we did was produce this white paper, which takes the global action plan on AMR and then filters it down to be the things that are specifically of interest to dental teams and dental organizations. And then we said, well, there's no point just having a white paper, because a white paper will just sit on a shelf somewhere. So we really need to know that the dental associations have picked it up and have done something with it. So we made a pledge. And the pledge includes the 10 actions, or the 10 commitments, if you like, within the white paper. You can see them down here. And we went out to all of the organizations within FDI and we asked them to sign the pledge. And you can see here a little map on the right-hand side of the 81 organizations which have signed the pledge. And then we said, well, it's no good just to have signed a pledge. We need you to have done something about that pledge. We want to know what you've done. And some people have done more and some people have done less. You know, for example, look at the first bullet point there, awareness raising. All we're asking them to do is make a clear and public commitment to tackling antibiotic resistance. So that could be as simple as during World Antimicrobial Awareness Week, just putting a post on their social media site that they as an organisation support AMR and support antimicrobial stewardship and national actions. So we did a survey in the last year, and we will be publishing the results of that in the not too distant future. There's some really innovative ideas and clever ways that some of the countries have been taking things forward. And during World AMR Awareness Week, we happen to be in one at the moment, but this was the poster that we put together last year, because we've done all sorts of innovative ways of doing. We have little videos that we put onto social media. We have poster campaigns. But can you see down here, there's a picture of me and Pramod. Pramod's a poet who happens to be a dentist as well. And he wrote us a poem about antibiotics. So he's a dentist from India who works in the UK now. And his poem is fantastic. And so if you go onto the FDI podcast website and look up dental checkup, then you will be able to hear him reading and telling his poem. Oh, there you are. He's actually doing things. So we've talked a lot about when it is appropriate to prescribe antibiotics and to use antibiotics, but actually, if we can prevent infections, and you talk about infection prevention and control and prevent communicable diseases and the WASH approach, but the whole premise of WASH is all about communicable diseases. And dental infections are non-communicable diseases, just like urinary tract infections. They're not communicable diseases. Tooth decay leads on to infection. And if infection if infection is left to run wild, then eventually it needs antibiotics. And if antibiotics are used, then it leads on to antibiotic resistance. So we can combat antibiotic resistance by preventing tooth decay, because we get less tooth decay, we get less infection. We have less infection, we use antibiotics less often. If we use antibiotics less often, we get less infection, less resistance, sorry. So how do you get less tooth decay? Well, the only reason that people can get tooth decay is sugar. That may be something that you weren't aware of. It's very often when I'm lecturing to non-dental audiences, it's something that they simply don't know. You cannot have tooth decay without sugar, and sugar-sweetened beverages are one of the biggest causes of tooth decay. So if you can keep sugars to meal times only, reduce overall sugar intake, then you get less tooth decay. Fluoride can help protect teeth and prevent tooth decay, but you can't counterbalance too much sugar with fluoride, because it's just swamped, the effect is swamped. So if you can reduce sugar down, and if you can encourage people to use fluoride, have fluoridated tap water, maybe toothpaste and fluoride varnish, then you get less tooth decay, which is fundamentally great for having less tooth decay and less pain and less infection, but actually about improving the situation in terms of antibiotic resistance. Because antibiotics don't cure toothache, pain relief is best achieved by a dental procedure, not a prescription, which you've heard me say many times during this presentation. Here are some myths that I've kind of talked a little bit about as we've been going through as well. So dental infections need antibiotics to clear it before a dental procedure. The answer to that is no, that's a myth. You only need to do the procedure once and you do it right, and you do not have to have cleared the infection up before you do that. Antibiotics are necessary every time a tooth is extracted. Again, that's a myth. There is no evidence that it helps. Just take the tooth out. Prophylactic antibiotics should be given for 7 to 10 days after whatever the procedure is that you're using prophylaxis for. The answer is no. Only one preoperative dose less than an hour before treatment is needed. Again, dentists go on lots of courses, and they're told by lots of very confident people who are charging them lots of money to go on their courses that yes, antibiotics are very important, and you are a very special person for being able to prescribe antibiotics, and you need to give them a really big course because you're a very special person and it will really help your patients. And they never, ever, until they meet me, think about consenting patients to antibiotics, because when you consent someone, you need to think about the risks of the procedure that you're doing as well as the benefits. And dentists are very, very used to consenting people because we're doing operative dentistry all the time. We're giving procedures, we're taking teeth out, we're saying to them the risk of maybe bleeding afterwards and the potential benefits of it. But they never think of antibiotics as being treatment. They just give an antibiotic and tell them to go and get them from the pharmacy, or they give them the antibiotics direct. They never tell them about the risks of them. And I always encourage people, anybody who's prescribing antibiotics should be talking about the risks of the antibiotics as well as the benefits of them. And finally, antibiotics don't cure toothache. Toothache is usually an inflammation, not an infection. Dental infections can be life-threatening. A procedure is usually the quickest fix for a dental problem. And then check out the FDI World Dental Federation's free online course, Tackling Antibiotic Resistance, What Should Dental Teams Do? It takes the white paper and it puts it into a user-friendly format. It's a MOOC, a massive open online course. And check out the World Health Organization's antibiotic book, Oral and Dental Chapter. Thank you very much for your time.
Thank you so much, Dr. Wendy Thompson, for the presentation. I've learned a lot and taken home a lot.
Thank you.
I'm going to reduce my sugar consumption, definitely. We have a few questions. However, due to time, I see one in the chat box. Let me read that out and then we take the others later. It says, is there any relationship between smoking and
You've frozen. I don't know whether that's me that's frozen or you.
alcohol consumption and AMR in the motions for chlorhexidine effect for oral mouthwashes for dental infections or for dental procedures which are not even infections still pose the same risk as the systemic antibiotics? Thank you.
Yeah, so biocides like like chlorhexidine can be a problem. We do see resistance to chlorhexidine in the oral microbiome. So yeah, there is within the UK, one of our members of the House of Lords has been raising this as a question. You may remember that there was a I can't remember what it was called. There was a content of Colgate Total toothpaste, and I can't remember what it was called, but it was an antimicrobial that was banned because it was being shown to lead to resistance. So yeah. The question about smoking, I'm not aware of any links between smoking and resistance, but there's certainly lots of links between smoking and alcohol and oral cancer. And one of the big things I say when I'm lecturing, maybe not just dental audiences, but maybe wider audiences, is that death certification in the UK has changed. So it always used to be that if someone died from cancer, that their death certificate said they died from cancer. But actually, we know that people with cancer often die of an infection, and it's often a resistant infection that they die from. Because if someone's immune compromised, they don't have an immune system to look after them, then during their chemotherapy, then they'll be given an antibiotic for maybe a chest infection that they get, and then maybe a urinary tract infection that they get. And there are studies, more and more studies, you'll see them when you Google around, that show that actually people with people up with cancer often die from an antibiotic resistant infection. The numbers are really quite high. And so in the UK, they changed the death certification process to say that if someone died, whatever they die from, although it's mainly picking up the cancer ones, but if someone dies and within 30 days before they die, they've had a positive test for a resistant infection, then that must go on their death certificate as well as whatever else people want to put on there. So the cancer might be the thing that started the process to them dying, but it might not be the thing that they died from. It might be the chest infection or the sepsis or whatever it is that they've got that they didn't survive. Does that help?
Yes, please, it does. Thank you so much, Dr. Wendy Thompson.
No worries.
And we'd have to move on to the next discussion now. So would reserve the questions for later. Thank you again for your
Okay, I
time.
will need to go and get a train very soon, so I will have a look through the chat and try and answer anything now.
Okay. We'd also email the rest to you and then link them back to the people who asked them.
So can I just say that some people are asking about NOMA on here, and we
Yes,
don't know what the etiology of NOMA is. It's a neglected tropical disease that the World Health Organization made a neglected tropical disease last December, just less than a year ago. And it's so neglected that the actual etiology of it just isn't understood. They think it is linked to the nutritional aspects as well as the microbiome, but they just don't. There is active work going on, but there's traditionally not been very much. So if you're interested, go and Google it. There's more and more stuff out there since it was made a neglected tropical disease.
Okay, thank you so much. Thank you so much, Dr. Wendy, for your time. And we'll move on to the next session now. We really appreciate you taking your time out to enlighten us on oral hygiene and AMR. Thank you. So up next, we have a panel discussion on innovations in AMR surveillance, how youth can lead data-driven solutions. It's a panel discussion, and I'm going to hand over to the moderator of the panel, Manuela Kofi. Hi, Mimi. If you're on, you could take over now. Also, we are noting all your questions, so you can keep them in the chat section, and then we'd send them to the respective speakers to be addressed. We are sorry we can't take more questions due to time. The panel discussion will begin shortly. Dr. Wendy is still around answering questions in the chat box, so do drop your questions in the chat box. And we are going to begin this panel session now. Manuela Kofi, kindly take over.
Hi, guys. Please let me know if I'm audible enough.
Yes, you are.
Okay, thank you. Thank you very much. Good morning, afternoon, or evening, whatever time it is by you. I want to encourage you all that we are getting to the last part of today's session. If you are sleeping, please wake up. If your friends are sleeping, call them, wake them up. If somebody was in the beginning of this meeting, please go call them, ask them to rejoin the session because it's about to get extra interesting. To those of you who are not too fast at typing, you might want to get a pen and a paper for this round. If you are excited about this round, let's see some comments in the text space. Let's see some clapping. Let's see some excitement everywhere. Is anybody excited for this round? Are the participants sleeping? Okay, guys, we're going to need to hear some comments from you guys. Are you sleeping? Should we continue? Should we continue? I'm only seeing 2, 3 comments. Let me see 5 more. Okay. Now I know you guys are here. Thank you so much for being here. We really appreciate you. Today, we're going to have a panel discussion, and the theme is innovations in AMR surveillance, how youth can lead data-driven solutions. We want to know how the youth can lead data-driven solutions. So if you are like me and you are interested in this topic, like I mentioned, please grab your pen and paper so we can zoom into an exciting moment. We've got 3 speakers on the panel today, and I must say, it was quite difficult getting them over here. It's been quite a task, but we want you all to know that they have taken time of their busy schedules. So we'd be more than happy if you could pay attention to them. First on the list, we have our very own pharmacist, Yusuf Babatunde. Now, Yusuf is a Nigerian. For those of you who like this Nigerian Ghana Jollof war, just so you know, he loves Ghana Jollof. He's a vibrant youth. He's a pharmacist, an implementation researcher, and a human-centered designer with over 4 years' experience in the design, implementation, and evaluation of public health programs in the field of HIV/AIDS, antimicrobial resistance, and digital health. His current research work investigates participatory science through crowdsourcing to co-create public health interventions with the target beneficiaries. This community-based approach has successfully helped to create people-friendly health services while enhancing uptake. He's also the founder of AAA, for those of you who know AAA. It's an alliance against antimicrobial resistance. It's a youth-led organization with a mission to spread awareness and implement solutions addressing the drivers of AMR. His work has received numerous recognitions to travel scholarships, international conferences, medal honors such as the Diana Award 2023, grants to support his work. I mean, his track record is endless. He was also the recent regional projects officer for Afro. Ladies and gentlemen, you know him, you love him. Please let's welcome Fam Yusuf Babatunde. Fam Yusuf, can you please say a word so we can introduce the next speaker? Thank you so much for being here.
Thank you. Hello, everybody. Good to be here. Thank you so much, Mimi, for the big hype and introductions.
Thank you so much. All the hype is facts, guys. Don't be swayed. It's all facts. Okay, our next speaker is in the person of Mr. Daniel Rawingi. Please forgive me if I have crucified the name, but Mr. Daniel Rawingi is a social entrepreneur, pharmacist, and a passionate public health professional. He is the co-founder of Zihu Institute, a nonprofit and research organization that develops and disseminates data-driven, innovative, and scalable interventions aimed to address the overlooked drivers of infectious diseases and strengthen global health security gaps. I know today there are going to be some extra questions in the space just because of what I've read today. Now, know that he worked at the Capacity Development and Youth Engagement Manager at REACT, that is Action on Antibiotic Resistance Africa. And before that, he co-founded and led students against Superbugs Africa, where he served as a head of programs in the organization. He also co-founded and served as the corporate relations director of Rai Cultural Health and Social Innovation that focuses on mental health and sexual reproductive health interventions. Now, Daniel has vast experience in leadership, having served in leadership positions across different health platforms and organizations. He has served in multiple advisory positions and consulted with multiple organizations on AMR stewardship, development of resource materials and AMR courses, community and youth engagement in AMR framing, as well as communication. In fact, it's a tall list. Ladies and gentlemen, please let's welcome Mr. Daniel Rawingi. We'd like to hear a short word from you, so we call on our last panelist.
Sorry, I was on mute. Hello, everyone. It's great to be here with you today. Thank you for that very exciting introduction. Yeah, but I'm just like any of us here, also here to learn and also get to interact with us. And thank you for having me. I do appreciate it.
Thank you so much, Mr. Daniel. I like the fact that he said he's like any of us here. Well, I am yet to find an institute, so hopefully we'll get there shortly. All right, our last but not least speaker for the day is in the person of Farm Estelle Mbadiwe. Now, Farm Estelle is a pharmacist and the co-founder of Dacit Blue Foundations. For those of you who have a person like me to AMR, you must have heard of Dacit Blue. If you haven't, then you are missing in the space. She is a prominent figure in global health, known for her extensive project management experience at national, regional, and international levels. You name it, she's there. She excels in clinical practice, policy influencing, and strategic planning, and is committed to advancing the African health sector through her health consultancy. She's a Kofi Annan Global Health Leadership Fellow and has developed multiple national plans on AMR and IPC. She's also the Fleming Fund AMR coordinator and works on the Commonwealth Pharmacists Association AMR projects. Her areas of interest are AMR, youth leadership, data for health solutions, local innovation, patient safety, and quality service delivery. Farm Estelle champions public health initiatives in Africa inspired by Nelson Mandela's work. It always seems impossible until it is done. To those of you who love Nelson Mandela like myself, I'm sure this phrase is not alien. It always seems impossible until it is done. And this is what Farm Estelle believes today. So today she's going to show us how possible the impossibilities can be. Ladies and gentlemen, please let's invite Farm Estelle Mbadiwe. We'd like to hear a word from you, ma'am.
Hi, good evening, everyone. Great to be here. Thank you so much for the great platform. Always excited to engage with Pan-African colleagues as we drive for developing this continent that we all want it to be. So thank you, and over.
Thank you. Thank you so much. Ladies and gentlemen, I'm sure we're all privileged to have these amazing people on today's panel. We're going to dive quickly into the questions. But before that, we'd like to ask the panelists, Mr. Yusuf Babatunde, what drives your motivation for AMR? In a minute, we want to hear from you. We'll take a response from all three panelists, then we zoom into our questions for today. So to Yusuf Babatunde, we'd like to know, why AMR?
Great. Thank you so much, Mimi. That is a very, very, very tough question. I don't think anybody has asked me that before. And to put it simply, I think the data speaks for itself. When you compare AMR, when you compare the number of both attributable and associated death with AMR compared it with the big three, the malaria, with TB, with HIV/AIDS, you see a very huge significant difference in the possible cost of AMR deaths that could be so much bigger than the big three combined in the next few years. And one, because there's a very, I feel there's a little attention being paid to it at the national level and even at the international level. If you compare the amount of funding that's been invested in malaria, in HIV, in TB compared to what AMR, despite the fact that AMR can cause more deaths than the big three combined, it just shows that huge gap in terms of we still calling it a silent pandemic. And it is very important for us to kind of put the issue into people's mind, letting people understand that AMR, even though AMR is a naturally occurring issue, it is still largely driven by human behaviors. And therefore, we need to be able to fight for ourselves, and ensuring that we do not go back to an era where a simple cut could cost lives of patients, of people, and so on. So I think that kind of summarizes why AMR. Yeah.
Thank you. Thank you so much, Mr. Yusuf. We move on to Farm Mbadiwe. Please let us know, what has your drive been? What has your motivation been? Please tell us why AMR.
Yes, thank you so much. It's actually great to have Yusuf and Daniel as co-panelists because they're both doing great work across the continent. For me, the drive why AMR, just to give a quick little background story for my journey in terms of my career. Like you mentioned, I'm a pharmacist. My first job as a pharmacist was actually at St. Mary's Hospital in Paddington in London. Some of you may know that's where penicillin was actually discovered in the basement by Alexander Fleming. As you know, you may know the story, accidental discovery, so to speak. He left some petri dishes exposed and went on holiday and came back, and there was this growth that that started the discovery of penicillin, so to speak. So starting there, I, as a young pharmacist, bright-eyed, bushy-tailed, seeing my first experience of AMR was sort of a patient that had a small cut, cellulitis then to the wound, and he started treatment. Like I said, I was a new pharmacist, and I thought, we've learned this thing in school. This patient will have maybe a few days treatment and be discharged home. To cut a very long story short, he ended up staying in hospital for 6 months. They were calling medication at the time that, colleagues from the London School of Hygiene had to come in and really have a lot of specialist treatment and of course, very expensive. And I thought, this is very shocking. Like, I thought this was going to be a few days treatment. So to turn around and then be working in Nigeria, full circle now working in AMR. And for me, I'm very intentional about what the data says. And there's a lot of reports about what happens in Africa. If you remember during COVID, there was a lot of, posts and insinuations that, the numbers of deaths in Africa, there'll be dead bodies all over Africa. But we're collecting data. I can speak for Nigeria, definitely. We're reported on the data. And so the data really shows you what can be done when you have the right information. So AMR, like Yusuf said, the numbers say malaria, TB, HIV. But if we think about them, they're also antimicrobial resistant situation because they're all coined as AMR, but a lot of people don't capture them as issues around AMR. So the goal is, how can we really use the knowledge and really create solutions that really speak to our local context and really drive the narrative and shape policies and decision-making for us using our information, our data, and strategies that are localized. So that's really the drive. And to make sure that, does the data translate to the reality? Is it as bad as it is? Is it worse? Is it not as bad? So yes, so really, trying to see what the picture really speaks to. Thank you, and over. I can't hear. Okay, she's muted. Sorry, is it from my end? I can't hear anything.
Yeah, I think maybe
Yeah.
you're muted.
Someone. Okay.
Maybe.
All right.
Okay.
Thank you so much, Carmen Badue. That was a bit of technical. Thank you. Thank you so much. We'll hear from Mr. Daniel Raungi, and then we move on to our questions for today.
Okay, thanks so much. I think Estelle and Yusuf have shared it all. Just to save on time and also not to repeat, I concur with all that they have said. But I think for me, also it's quite a long story in terms of how I came to learn about AMR. I think when we started, it was quite a neglected area. And given that there was really little happening, and the way that I kind of learned about it, and it was the kind of the story of a young child, and it kind of exposed me to what was happening, especially in low and middle income settings here in Nairobi, especially in the urban informal settlements. So that's really what drove our passion towards community engagement. And when we started working on this, we realized that, the gap was more than we had anticipated. Nevertheless, I think these are questions that I would like to maybe pose back to all of us. If we don't do it, then who will? This is our continent, and it's home to each one of us. So I think we all have to, set in some interventions. I think one of the things that motivates me is one of the Nobel Peace laureates, who was from Kenya. She was called Professor Wangari Maathai. And when she used to talk about environmental conservation a few years ago, quite some years back in the 90s, really she had seen what climate change could actually, cause. And then there was quite a silent here, and no one really was really listening a lot, but she pushed on. So I think also learning from people who've engaged in social change earlier than us, I think that's also what keeps us driving. And I think I do share this story a lot in those that I engage in and in different platforms. Yeah, thank you.
Thank you. Thank you so much, Mr. Daniel. Now we move on to the questions for today. Now, the first question goes to Farmer Still. Farmer Still, we want to understand what the key gaps in AMR surveillance in low and middle income countries are. As founder of Dasset Blue, can you help us understand how the youth involvement addresses these gaps?
Okay, thank you so much for that. As I'm saying this, of course, the context is different. Across the continent, the capacity across the continent varies a lot. So generally, we'll say, there's limited or not, should I say, sub-optimized infrastructure. There's some challenges in the infrastructure. This is the actual infrastructure to do surveillance. We're looking at some gaps in data. So some data is being collected at some facilities, but sometimes it's not coordinated enough. And I'm speaking on this from experience. I know when you introduced me, you mentioned that I'm a Fleming Fund country coordinator. I was the Fleming Fund country coordinator. I'm no longer in that position, but we're looking at the coordination of surveillance across One Health sectors. So the data is being collected by some sites, but a lot of time is not coordinated, so it's not coming to the national. So that decision is not being made. I mean, that data is sometimes not being used for decision making and to advance policy. So there's this whole concept of this data iceberg. So we just see the tip, that just the tip of the data is what is sometimes being collected or being used, but of course we know there's a lot of data sources, so that's a gap. The capacity issue, in terms of the human beings to actually do some of the work, is limited. I'll speak for Nigeria in this instance as well. We have a lot of people leaving the country. We call it Japa, that people are leaving and going to other climes for opportunities, which is driving a lot of challenges. So you're seeing there's capacity gap. Definitely there's gaps in advocacy and public awareness. And we always go back to the funding and the support to do and optimize the solutions that we need. So what the youth can do, I think the youth have a huge role to play in terms of being solution providers to a lot of these challenges I just mentioned. They can work as, build their skill set and build that capacity for succession planning, in terms of being those players on ground, those foot soldiers, so to speak, to gain that expertise on data collection, analysis, and utilization of data. They can definitely do a lot in terms of innovation and in terms of community engagement. There's a whole lot that the youth can do. And I'll give two specific examples in terms of how they can work in the succession planning space and advocacy. So just in the experience of Dasset Blue Foundation, we run an internship mentorship program. So we build the capacity of Pan-African One Health youth using AMR as a platform, but these skills are transferable. So we're teaching them skills around data collection. We're teaching them skills around advocacy, understanding the fundamentals of AMR and how they can really be leaders, leadership skills. So really, really practical solutions to see how we can create that succession planning pipeline for public health leaders in the region to really profile solutions to some of these challenges we're seeing. And in terms of advocacy, like I said, we need to have the youth at the table for advocacy, to push that advocacy message. My colleague Yusuf is here on the call. We just ran an advocacy letter writing workshop recently, and we're encouraging Pan-African youth to share. We've developed these letters across the One Health sector and for parliamentarians. We're encouraging the youth to share these letters, to submit these letters in their country, to start being, to push for those messages and to be at the conversation for advocacy. So this is something that we really encourage the youth to do, because if they're not at the table, they'll have limited opportunities to really profess solutions. So my colleague, we can share the link for the youth on this call to also participate in this. Submit the letters, download the letters, and follow up with your leaders, your One Health ministers, your parliamentarians, to really, push for that advocacy for the youth voice to be heard. So I'll stop here and over to you. Thank you. So I think my colleague just shared the link for you to participate. It's got guidelines, and feel free to do that if you want, and join the advocacy drive across Africa. Thank you.
All right. Thank you, Dr. Mbadiwe. So for all of us who are paying close attention, we have a call to action. The youth needs to get actively involved in the things that are happening. We can't sit in our houses and say, we want to bridge gaps. We need to get on the ground, like she said. Engaging a lot of these aspects will give us hands-on experience. Thank you so much, Dr. Mbadiwe. Next question goes to Dr. Yusuf. Dr. Yusuf Abatunde. In your experience, in your line of work so far, what would you say are some practical ways that the youth can actively participate in data-driven solutions, especially at the community level?
Great. Thank you so much, Manuela. Also a very interesting question. So firstly, I really think that there are so many opportunities for young people, especially in terms of AMR surveillance. Many times we limit youth's involvement to AMR awareness alone, right? So we think every young person is doing AMR awareness, AMR education, which is very fine, and which I'm very proud to say many youth in the African region have really taken the initiative to start their own little campaign, to get funding in their own capacity, and to do awareness programs. Really awesome. And that is in line with the first objective of the WHO's Global Action Plan on AMR, and usually many of the countries' national action plan as well. However, a very crucial aspect as well is AMR surveillance, and AMR surveillance helps us to kind of improve our understanding of AMR. Without data, it is difficult for us to kind of predict and understand how these resistant microbes spread, how they develop, even across both the human, animal, agriculture, and also the environment sector. So this is a very huge gap, and one, because we are now leaning towards digital technology to kind of collect data. I've seen many African countries using genomic surveillance. These are very, very important tools. And I remember last week I was hearing a presentation from the African CDC, and they presented very, very important data that no African country currently has more than 20% laboratory capacity to conduct bacteriology testing, right? And that's a very, very important part of AMR surveillance. Without bacteriology, it's difficult for us to understand what specific bacteria are causing the resistance, which ones are getting spread and whatnot. And so I asked that a question. I said, all the capacity building session that they develop, I've never seen a young person being present. It's always somebody that has a master's degree or a PhD degree. And I feel that if they can involve young people, regardless of their educational level, on how to use some of these tools, or how to use glass, on how to collect data, how to analyze data. And we have many young people on this call that are probably data analysts, right? And these are very, very crucial skills that allows us to interpret that data, to make meaning of it, and to convert them into papers or into policy documents that we can then use that data to kind of make key recommendations. We can use that data to make a case for IPC, for WASH, for whatnot, right? So imagine a situation whereby young people's involvement goes beyond education and awareness, where we can go to the hospital, we can go to the field, for instance, to determine if hospitals with strong IPC WASH programs have lower rates of antimicrobial resistance compared to those that have lower IPC programs. If we can collect some of those data, it's very, very possible for us to now, make a good case to the government of our country and say, oh, from the data, you can see that if you develop and if you enforce strong IPC programs, you can significantly reduce AMR, right? So I think one, we need to increase more capacity of young people in terms of AMR surveillance. We need to involve them in the GLASS programs. We need to involve them in the Fleming Fund programs. And one is that young people are very, very adaptable. We are very tech savvy. I'm sure we can easily understand some of those tools very quickly. And also, we've seen many young people now having startups, help startups for them to develop apps, develop softwares that have been used in health financing schemes, in universal health coverage. So why not AMR as well? So if young people's capacity are built, we can even by ourselves develop mobile health apps that can help in data collection, and this will definitely enhance data availability, but also like enhance a very rich culture of accountability as well from the side of
Guys,
young
I'm
people.
sorry.
Yes, Mimi, go ahead.
Please let me know if I'm audible. Can anybody hear me?
Yeah.
All right. Thank you. I'm sorry, Dr. Yusuf, I lost you at
Yeah,
some point.
go ahead.
Okay, thank you. Thank you so much. All right, we take our next question for this session, and it goes to Mr. Daniel Raunki. And we want to know, how do innovative technologies such as AI, big data, and genomic sequencing reshape AMR surveillance efforts globally?
Okay. Thank you so much for that question. I do appreciate, and also to just complement what my colleagues have said. I think, as Yusuf was saying, there's a lot of traction in terms of education and awareness. Those are the main initiatives that they're engaging in. But partly, I don't really maybe point a finger in terms of a lot of traction going that. But I think it's the way that even youth engagement is currently perceived as stereotypes, where young people are just seen as agents of advocacy, as the pressure groups to work with the government and all that. And we kind of have a bit of a narrow definition of what youth engagement means. And I think this is quite not right, because even as we talk about young people, this is a very dynamic group. This is a very group with different people from different backgrounds and with a variety of expertise. And the moment we do that, we also kind of limit ourselves. And also, when we are talking about the involvement of young people in AMR, most of the time we tend to narrow ourselves towards human health, animal health, and environmental health. And we forget that other disciplines also have a key role to play in terms of AMR mitigation. And I think this question is quite essential, since it's also kind of points out to the need for multidisciplinary engagement, whereby we now engage people with a bit of tech experts, especially in some of the upcoming technologies such as artificial intelligence, machine learning, big data and all that, genomic sequencing. And I think it's good. One of the key takeaways that we take from this session is how then do we work in a disciplinary setup as a pharmacist or as a pharmacy student who is attending in this. How can you link up with people with different expertise to actually come up with these novel solutions that we can actually use in terms of developing interventions aimed at improving our capacity in surveillance. So now to address the question direct, I think we've seen a lot of traction in terms of AMR surveillance and what can happen, and I think we have quite a plethora of young people who are very well skilled in artificial intelligence. And in terms of AI, it's possible to actually use algorithms to ensure that we're able to, improve our AMR surveillance capacity. And this is true, especially in terms of, identifying some of the patterns and some of the trends based on the data that we collect. But this is only possible if we already have that data. So as Farmestel said, without this data, then it becomes quite difficult to also use some of these technologies. But if we are able first to build our capacity and then leverage on this and apply and use this data to actually generate interventions on the same. Other ways that we can use, artificial intelligence, especially, I think we were listening yesterday in the session that I was in Kenya. I hope I'm still visible. Sorry, I'm still audible. My network is a bit shaky. And it was a clinical application that have actually been developed whereby you're actually able to do a bit of real-time data input and actually real-time data analysis, especially as you're doing the ward rounds. And this has really helped some of the facilities that were presenting some of the studies that they're actually doing in terms of improving their antimicrobial stewardship interventions. And then you realize we may not have a lot of data, but we still have some data. What happens is maybe it's quite unstructured, it's quite not standardized, and sometimes doesn't exist in very central platforms. And so, nowadays we have these, natural languages processing, LNPs, and it's possible to actually use some of these tools to actually, extract this data from, different sources and compute it to actually get useful findings that you can actually work on the same. In terms of big data, I think still on the same. It's just to ensure that, especially now, for example, for surveillance, whereby we are trying to advocate for, a One Health approach in terms of seeing, combining, human health, animal health, and environmental health, and generating some of these findings that we might miss out if we just work in surveillance silos. So I think these are an area whereby big data analytics can actually help us in terms of integration of these multi-sectoral data, and this can help us a lot in terms of especially in terms of identifying cross-sector resistant patterns. For example, for issues to do, for example, with some of these prevalent zoonotic infections that we see in our countries. On the issue of genomic sequencing, it's also an upcoming area, genomic sequencing and bioinformatics. And one of the ways we can actually work with it is especially in terms of, issues to do with outbreak tracing, especially, for example, when we have some of these emerging infectious diseases and some of the recurrent outbreaks that we experience in our different countries, especially some of these foodborne illnesses. And so it's possible to actually elucidate and determine some of the origins and how these outbreaks spread. And with this data, it's quite easier to actually come up with evidence-based information, and can actually help in terms of rapid containment, or ensuring that the strategies that we put in place are actually the right one, and able to contain this in good time. There's also the issue of identification of resistant genes, and also mutations, and this mostly is called pathogen typings, and it's able to help us understand resistance is not something that is static. It's something that continues, driven by the environment that the bacteria is exposed to. We have ongoing mutation, and so such pathogen typing can actually help us in terms of tracking the evolution of these resistant strains, and how how these mutations are actually happening in some, especially in some of our priority pathogens. And one of the things that is also quite growing in the same, and I think there's a bit of research happening in some of the universities, I think in the global north, the issue of personalized medicine. And I think if we're able to use some of these genomic insights that we're able to elucidate from some of these technologies, we can actually be able to develop some tailored treatments that can actually help in terms of misuse of antibiotics. And maybe as I finish, I want to share with us one of the innovations that I've actually seen here. So we have been running a 2-day symposium here in Kenya, where I've been part of the coordinating team. And one of the innovative studies that was being done was we have a bit of data surveillance data in Kenya, and they actually used a bit of artificial intelligence and machine learning to actually collate this data and develop some guidelines that they can actually use in their facility. And so I see it's possible to actually, even in our facilities, if we have good quality data, can even be able to use some of these tools to actually develop antibiograms that are quite quality antibiograms that reflect the epidemiological profiles within this where the facilities are actually based. So that's just in summary what I can respond to that. Thank you.
Thank you. Thank you, Dr. Ringi. Dr.
I think you're breaking me.
Can everyone hear me?
Yeah.
Okay, thank you. Thank you so much. Thank you, Dr. Waringi, for that summary, he said. Okay. Dr. Yusuf, would you like to add on?
I think Daniel has covered the most part.
Most part of it. Thank you. Thank you so much. Mbadiwe, anything you want to put in there for us? Or would you also say Dr. Daniel has covered everything?
Yeah, I think he touched on the key points. Yes. Thank you.
The key points. Thank you. Thank you so much for doing justice to that question, Mr. Rawingi. We move on to Farm Estelle. Now we want to know how young professionals and students in healthcare, technology, and data science contribute to building robust AMR surveillance systems. If you can share even a practical experience, your personal experience, who we can learn from. Lots of young people on this platform today, and they'd love that heads up.
Yeah, no, thank you so much. Yes, absolutely. Like, my two colleagues have said, there's a lot that can be done. So these skills, sometimes people have these skills, these data science skills, but it's how you now translate it to practical solutions, right? So if I can share a practical example, like I mentioned earlier, we run an internship mentorship program. And as part of the program, we have a component of it that is teaching practical skills on data science and some of these skills for technology, leadership, etc. So what we do with the teams, with the One Health Youth, is once they've developed the skills, they practicalize it into projects. So some of them have worked on projects on antimicrobial stewardship, on surveillance, looking at data from the different countries to really analyze it and develop some kind of policy brief on what a policy brief to use for advocacy could look like. And when they're doing this, I think what we try to do is get them to look at the core data, analyze it, do some visualization, and then translate it into this whole concept of citizen science. So they're trying to bridge the gap with the scientific knowledge and then trying to work with communities to really do community engagement and see what this translates to. So they're using the output of the analysis and the data they did to do, One Health lesson, One Health leadership training, and really get the communities buy-in on what these challenges mean to them. Because at the end of the day, we can all, as we say sometimes, sit in our offices here in Abuja, in Nigeria, discuss high level and how does it translate to community community action and to really impact at the community level. So I think, if we're trying to get them to have the core skills, develop the skills, and sometimes, like I said, these skills, some of the teams that have to work in this is you build this multidisciplinary concept, right? You're bringing colleagues from human health, trying to look at animal health, look at environmental health, and see how they can collect data from their projects. And, a lot of them have gone on to do fantastic projects, even after the internship program, on collecting real data from their countries and their communities to really translate it to impact and developing policies, which is why we're so strong on the need for advocacy, more advocacy for the youth, to really sit at the table and to be able to showcase that they have the skills, they can contribute to the conversations and the discussions, and they really they can be change makers, so to speak. So, this concept of citizen science, I love it, because you're now, as we say in Nigeria, you're speaking the English in the scientific way, and then bridging it with the reality on ground, getting the community participation, getting their findings from that realistic. What does antimicrobial resistance mean to you? What does it even mean? We did, we've done vox pops or data collection at that level to say, we say AMR, we sit in here and say AMR all day, but what does AMR actually mean? And translating the science to actual solutions and impact at the community level. So yes, so that's what I'll just say. So practicalize it. I love the concept of practicalizing whatever expertise and capacity you have. So once again, I call the youth to participate in submitting the letters, and not just submitting it, following up after they submit, to really try and push at whatever level they're submitting for them to be part of the advocacy discussion and have their voice heard. So over.
Thank you. Thank you from Estelle. Estelle makes us understand the importance of practicality. She says, if you submit your letters, don't just leave it at that. And also the youth today, we can attest to the fact that we are fond of that. We submit the letters, that's all. I've done my part. I sent it in. They never called me. Have you followed up? For all you know, what you even sent out has not even reached your destination. So today, let's all take a practical note into the steps that we want to achieve. Moving on to Mr. Daniel Raungi. What unique perspectives or advantages do young people bring to the table in AMR data collection, analysis, and policy advocacy? Once again, what unique perspectives or advantages do young people bring to the table in AMR data collection, analysis, and policy advocacy? Is there any way we can use some of these aspects to our advantage so we can further practicalize, like Farm Mbadiwe is talking about?
Yeah, thank you for that question. I would be interested in why the three, why data collection, analysis, and policy making, and I'll start by maybe sharing a bit of this. We also don't want to find ourselves in a place whereby young people are just relegated to, data collectors. They're the ones who do the heavy lifting. Get the less credit. So I think it's also good to look at this. Even as far as we try to capacitate young people to be very agile in terms of data collection, analysis, and policy advocacy. It's good we follow up to ensure that those who collect this data, the young people who collect this data, the young people who conduct the analysis, and those who are quite active, they also appreciate and are recognized in the in the evidence dissemination wherever it may be it research papers, be it government reports, and reports from different organizations. And I speak this from experience, having engaged in this space for a while. Sometimes you might find yourself doing a lot of some of this work, but in terms of dissemination, young people are not quite recognized. But nevertheless, just to address the question that has been asked, I think in terms of data collection, one of the things that also as we focus on surveillance and mostly on surveillance on AMR, we mostly look at AMR surveillance and AMU, that is antimicrobial use and antimicrobial consumption surveillance. And one of the things maybe we don't really focus on a lot is community surveillance. And community surveillance is also quite important. And maybe I'll share from a context of Kenya, where I come from. I know it structures do vary in different countries in terms of how surveillance, especially community surveillance, is done. And in Kenya, we have the integrated disease surveillance and response. And you find that there are guidelines that have been developed in this. And the aspect of community surveillance is to ensure that, we're able to detect early some of the emerging diseases at the community level. And the data collection can actually be, these are good routine data collection. And this data can be used in decision making, at the local facilities. And you find that most of this work is done by community health workers, and we've been pushing, to see whether, in terms of community health workers, some of the times you find that we have really a few young people actually being engaged as community health workers. And I feel this is a space that also we need to engage young people, building their skills so that at least they're able to work at that community level. And the reason I say this is because, we have quite a lot of skilled young people who've done, different programs in community health programs and all that. But you find, sharing from a case study of Kenya, most of these young people, they are home, maybe they haven't been able to get some employment opportunity, or maybe to start their own thing and have it running. But our governments, when they're looking at community health promoters or community health extension workers, depending on how the same is termed in our different countries, they mostly don't look at these well-educated group. And the reason for this is because if we're able to engage young people at this level, I believe there's a niche that you can be able to really learn a lot about, community participation, different ways of, data collection. And through that, you can be able to generate actually quite a good experience and expertise that you can use in terms of, maybe advancing your career, starting your own initiatives, having had that good experience in terms of community engagement. And in terms of data collection, one of the things that we also need to do is, training, ensuring that we as young people are well informed in terms of, the different data collection strategies, and how to ensure that, the data that is collected is quite of good quality. And the same to do with analysis, that we're able to conduct rigorous analysis. And some of the advantages that young people do possess is, I believe, we as young people are quite open-minded, and this means that we are quite flexible in terms of learning new things, trying to experiment with upcoming technologies and all that. And this way we can be able to develop novel ways of data collection, some that have not been used. And when we talk about data collection, it can be from the community, from facilities, but also kind of standardizing or organizing some of the scattered data that already exists, and cleaning it up and making sense out of this data that already exists, but it's not quite standardized, or it's quite scattered. So this is one of the ways we can actually do this. And given the technology, technology agility of young people, I believe nowadays we have quite a lot of online courses, to do with data analysis, statistical analysis, and it's easy for us to learn these things, being proficient in some of these data analysis software that we use, be it SPSS, be it Python, be it R, and also, also other softwares that we actually use for, for qualitative data analysis. And data visualization is also quite an upcoming, field. And, there are quite a lot of opportunities, especially in data visualization. So this is also something, and it's either visualization of the data that you have, but also there's a lot of geospatial modeling and also use of, geospatial information systems to actually map out some of the disease spread and disease transmission and all this. And so we have these data visualization platforms, for example, Power BI and the rest, that these are things that we can actually learn online. And given that we are quite flexible, I believe these are things that we can quickly adapt to or quickly learn. What matters is, do you have the interest, and do you have the commitment to do this? And also, as we learn these things, it's good to have like an end focus in mind. Even when you're learning about data analysis, data visualization, and all this, do you know what you want to do with this data? So I imagine from a position, if you've decided that this is the area that you want to specialize in, in AMR mitigation, looking at it, and you kind of invest a lot of time in this learning. And what happens is that we have very little expertise in this in this field, especially in the AMR landscape. So that means it also opens up a lot of opportunities, be it employment opportunities, be it starting your own stuff. We have also quite upcoming open competitions that you can apply to. There's one called Bivil I don't know whether we have heard of it. It's called under the AMR register. So every year they have like a competition whereby they actually invite applications for people who have innovative ways AMR surveillance strategies, especially through use of artificial intelligence and big data. I'll share the link in the group, so that if you're interested, you can also maybe apply for maybe for the next and everything. And you find that we've had quite a number of people from or teams from low and middle income countries. For example, this year we had one from Kenya, one of the county level hospitals. So county level hospitals are actually, for example, regional hospitals in other settings. And I think this was just a dynamic team, maybe made up of several pharmacists and all that, and just a multidisciplinary team, and with a few tech people, and they were able to come up with quite a good intervention on the same. In terms of policy and advocacy, I think this has really been addressed quite much. But I look at it from data dissemination. We most of this data that exists is, it just exists in reports. It's really not translated into ways that can actually be taken by policymakers, or do we really use it to make sense of what our situation is in our countries? So I believe this is also an opportunity, especially in terms of what was being said in terms of simplifying this data, contextualizing it to suitable language that actually matters to the different people, especially in the policy space. Suppose when we present some of these data, it's quite complex, and maybe someone may not have that technical expertise to understand. But I feel if we have some of us actually focusing on this in terms of translation of this very complex or rigorous data analysis that has actually been done to simple language, or simple concepts that can actually be understood by some of our policymakers, and shipping this in some of the initiatives, the policy initiatives that are actually going on. For example, what Yusuf and Farmer Stella are doing in terms of the letter rating. So I think I reached there for now due to time. Thank you.
Thank you. Thank you, Mr. Daniel. I think in our subsequent sessions, we're going to ask our organizers. So we give Mr. Daniel one platform because I see he has a lot for us. Thank you so much, Mr. Daniel. We really appreciate that. Thank you. Personally, I have taken away the advantages that the youth will bring to the platform or bring to the space. The needed recognition that we can get is not just in a spot if we're able to gain. Thank you once again, Mr. Daniel. We really appreciate that. Our next question goes to Mr. Yusuf Abatunde. And we want to know what skills and competencies are essential for youth to lead AMR surveillance efforts, and how can stakeholders support their development? We understand the nature of this question, but we'd be glad if you can personalize it a bit. What has it been for you as opposed to what people think it is or what people think it is out there? If you can share a personal experience, please let us understand what the skill set and the competencies that are essential for you to lead AMR surveillance efforts is. And if you have any success story where there have been any youth-led initiatives, you can share that as well.
Yeah, thanks, Mimi. I'll try to make it very, very short because I know we're running out of time already. I think in simplest words, one is to seek knowledge, be very, very up to date in terms of AMR news, know what is happening currently, know what are the current trends. Something that I do, which is often very simple, is that I just go to ChatGPT and I say, what are the latest research papers on AMR in the region, for instance? And it's going to give me a couple of lists. And then I would ask it to summarize what are the key points that were in that paper, or I'll just go and read the abstract. It's as simple as that, right? Because you need to, first of all, build your own capacity before you can take any action. You need to be knowledgeable in the field. You need to be able to do these things. And this is really how stakeholders can like give you a seat at the table. If they see that you are not knowledgeable, if they see that you do not have any track record, it's very, very difficult. So I need everybody, every young person on this call to kind of take your own initiative, look at the whole AMR space, and if your interest is in IPC, if it's in WASH, if it's in antimicrobial use or consumption data, just take a niche and kind of build a capacity in that niche, and then try to have evidence to show for it. It could be through blogs, it could be through social media awareness, it could be through actual research papers. And I would think one of the most important skill that I've taken that has really helped me would be on research. And I'm super grateful to Pam Estelle and the Ducibly Foundation for incorporating research into the AMR internship program, which I was a part of. It was very, very crucial. I remember attending Professor Iruka's session on the research, and it just kind of opened my eyes to the possibilities that if I have this skill, I can always apply it to so many areas in AMR. For instance, I think about 2 years ago, we were at a hospital that there was a very high rate of hospital-acquired infections in that clinic. And so it only makes sense for us to, let us determine what is the antimicrobial consumption data in that clinic, what is the antimicrobial use data, what are the factors that influences prescribing and dispensing among healthcare providers in the hospital, and then how can we then develop solutions to kind of target those barriers, because everything that we're doing needs to be again evidence-based, right? So we need that data first to make our case, and then it will be very, very easy for us to then develop some of these solutions that we envision. And that's again, that people do ask me that, why do I think AMR communication is very difficult? And I think the simplest way to put it is that I think the risk perception is very, very low, right? I think the public do not understand how much of a problem AMR is. It's still, in quote, a silent pandemic. We still do not talk as much as we are supposed to. And also because there are so many actors involved, right? There's human health, animal health, environmental health, and it's very, very difficult. AMR alone is difficult. combining the One Health concept and AMR is even more difficult, right? For people that are not scientists or they are not in the field, right? So it's very, very important for us to kind of simplify the AMR messaging. Even though it's data, you need to be able to communicate what AMR is in a very late term. You need to, and something interesting might be, let's ask a group of people, maybe 100 people, let them explain to us what they feel AMR is, and you see that people really do not even understand it. We've seen the same case in antibiotics. People feel antibiotics are drugs that are used for anti-inflammatory. They are drugs that are used for cold. Many of these definitions, many of this myth and mythology, it kind of affects the way people use antibiotics in the community. And so I think I am a success story myself. So build your research skills, strengthen your knowledge base, chase every reference, and then use that knowledge to do something. It could be a research, it could be a solution, it could be a campaign, it could be whatnot, but then ensure that it is evidence-based, right? And and you'll probably be more successful that way. Over.
Thank you. Thank you from Yusuf Babatunde, live from Nigeria. Thank you so much for that. We'd like to take our last set of take-home messages from our panelists because we still have just a short session after here, but we guarantee that we will take your questions and email them to our panelists so they can answer them and then we'll revert accordingly. So now we want to take in just 1 minute, take-home messages from our panelists, our speakers. What would you like the youth to know today? It can be a call to action, it can be a personal story, it can be anything that you want to share to either encourage, whatever you want to do for the youth on this platform today. We just want in 1 minute your take-home message for us. It can be from yourself, something you learned or picked along the way. I'm going to start from Estelle, by the way.
Yes, no, thank you so much. This has been an amazing session. Thanks to my co-panelists for great insight that they shared as well. In terms of a take-home message, something that I always share with whenever I have the opportunity to engage with youth, including in our mentorship program, is to say, lead with your value, right? So, and what that means is that, like Yusuf said, you have to build your value so that you're able to be a value addition to whatever conversation or what context you find yourself. So for example, I remember there was a panel that was being put together by Chatham House at the time. And I looked at the panelists, I liaised with some colleagues and I said, I can't see any representation from Africa here. And, reached out to the team. Long story short, I got invited to be a part of that discussion. So I could have gone to that discussion and ticked a box, right? And just be like, oh yes, I ticked a box. I'm here from Africa. I'm a woman. I'm on the panel. Box, tick, 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 tick. But I came there with a lot of information, a lot of insight shared. And, it was able to really add value to the conversation. I say to the youth, I say to the guys on this call and beyond, your voice matters. Your impact is possible, but you need to lead with your value. You need to bring something to the table. You need to develop your skills. You need to build yourself, like Mrs. Yusuf said. And then when you build yourself, you're then able to be a value addition. And then you'll be wanted and called to be part of conversation, not just a tick box. Yes, we have a Black person. Yes, we have an African. Yes, we have someone, a youth. We've ticked the box, but there's nothing really, there's no substance. So that's my message. And of course, like Mrs. Yusuf said as well, we're saying that the youth should build their capacity, engage in more opportunities to collaborate cross-disciplinary, and really identify and localize the solutions they're providing for Africa. With the call to action, of course, we're saying that you should work on advocacy in your capacity, and we're working and collaborating on that piece of work with AAA. And, we're pushing for the youth to be part of the conversation and build that advocacy. But definitely the tag is lead with your value and ensure that you add value and you're a solution provider in wherever platform you find yourself. Thank you and over.
Thank you from Estelle Mbadiwe. Lead with your value and ensure that you are a solution provider. That's one really good take home. For those of us on this platform who don't know how to do anything but cause problems, please, today you are encouraged to change. Lead with your value and become a solution provider. Provide solutions, because if you can answer mind-boggling questions, then you are definitely value. Thank you so much from Estelle. We really appreciate that. We'll hear from Mr. Daniel Raungi in just 1 minute, please. Let us know what your take-home message is for our panelists here today and our students as well.
Thank you. Yeah, so I first want to thank my co-panelists, Estelle and Yusuf, for very insightful submissions. I think I'll just pick it up from where Estelle has left it. I think for me is just to realize that the interventions that we need in AMR are quite diverse, and so we really need a lot of multidisciplinary expertise. And there are different ways to actually handle this. And I think this conversation actually it's a very well-intended topic, because it expands the scope that young people can actually engage, beyond maybe the really emphasized areas. And one of the things that I would maybe want to say is that I think it's good to identify your passion, to identify your interest. What do you love doing? What's your interest areas? Where do you want to go in terms of your career growth and all that? And with that, identify, this is what's happening in AMR, where are the gaps, and, locate your niche. And then, as Farmer Stella said, build your value. Thank you.
Thank you. Thank you so much, Mr. Daniel. Mr. Daniel says, locate your niche, find the gaps to fill. Because if the glass is full and you are still adding water, then probably the world may not see your relevance. So find the gaps and fill them. Those are the spaces that need filling. Thank you so much, Dr. Daniel. We appreciate you, Mr. Rawingi. Now we're going to hear from Farm Yusuf Babatunde. Okay.
Yeah, thanks, Mimi. I think I'll just say, firstly, be courageous enough to start, and then be persistent enough to catch a few lucky breaks and do it well, do it hard, and ensure that you love what you're doing, basically. When people ask me, oh, Yusuf, how did you start AAA? To be honest, I do not know myself. I just knew that I built up that courage to say, oh, we did not have any youth-led organization on AMR in Nigeria at that time. And I saw what Daniel was doing with South Africa at that time, what Eric was doing with RBA initiative. And I said, why not, right? And I just came up with a plan, went for it, invited some of my friends, invited Naomi to join me, and it's been 4 or 5 years now currently, and we are still standing, right? So I've built that courage. AMR to me is the greatest public health challenge of our time. And as young people, we are very uniquely positioned to lead the change against it. If you look at the forecast data for AMR, you see that the data where it affects us the most is in the future. And where young people would be the one to live the longest to witness that future, right? And so with our creativity, with our passion, we can revolutionize how AMR data is collected, how we make advocacy, how we educate our communities, how we can then make a difference, right? So this AMR fight needs bold and data-driven solution. And I'm kind of urging everybody on this call to kind of deliver them. Let's all step up, let's collaborate, and let's lead the way to a more healthier and a more resilient future for all. Thank you.
Thank you, Farm Yusuf. Farm Yusuf is tasking us to be courageous enough to start. This is the most difficult one, guys. Oh my God. That's especially for those of you who have been pushing away tasks for only God knows how long. We make New Year resolutions, we don't get on it. That research paper, write it. That email, send it. That question, ask it. That is how you are going to cause the differences. And it's not enough to just start. You need to be persistent enough to keep it going and to get lucky breaks. We're all praying for lucky breaks. So thank you so much from Yusuf. Thank you, Dr. Raungi. Mr. Raungi, thank you so much from Estelle Mbadiwe. We do not take your efforts for granted. We appreciate you so much. Personally, I have learned a lot from this discussion, and I'm sure the participants can attest to that fact. Once again, we appreciate you all for being here. this has been the panel discussion. Over to you, Miss Eleanor. All right, guys, please don't forget to look in the text space. There's a lot of valuable information. Okay.
All right, thank you very much. I am Eleanor Fondi, the Regional Project Officer for IPSF AFRO. So right now, we are just going to move to like a 30-minute brief youth networking session. I know that maybe some of us are tired, some of us are, who have been here since 2 p.m., but believe me, it's going to be worth it. So let's just hold on for the next 30 minutes while we invite our facilitator for the youth networking session. So, Gachina, are you there?
Yes, I am.
All right, thank you very much. So just kindly
Okay,
introduce
so
our facilitator before we just move to the networking session.
sure, okay. So we are now getting to the tail end of the program. And to wrap up today's session, allow me to introduce our final speaker for today. So next up, we have Dr. Mariam Zakaria. Dr. Mariam is a veterinary doctor who is pursuing her master's in global health and infectious diseases at the University of Edinburgh. She's the current project manager for Africa Public Health Student Network Initiative. She enjoys raising awareness about One Health topics, especially antimicrobial resistance and infectious diseases. She has organized several campaigns ranging from webinars, competitions, quizzes, and other activities focused on One Health and AMR. She was part of the organizing committee for the Global Antimicrobial Resistance Youth Summit in 2022 and African Youth AMR Forum 1.0. In the past, she has worked as the I saw her liaison intern for One Health Lessons, African continent representatives for International Student One Health Alliance, and the chair of the IVSA Standing Committee on One Health. She loves bringing people together, coordinating and managing teams to achieve various set goals centered around One Health. She looks forward to being a key active player in the One Health field in the near future. So for the next 20 minutes or so, Dr. Mariam will take us through the youth networking session. So Doc, the floor is all yours. You're welcome.
Hi, thank you so much. Am I audible?
Loud and clear, we can get you.
Yes. Okay, great. Hello, everyone. It's evening over here, so good evening. I hope you've been having a very interesting and educating session since the beginning of this youth forum started. I know I've learned a lot, and I'm sure you have too. We've been listening to so many discussions, so many presentations, and it's time for us to network. So if you're excited about this networking session, just type in the chat your name, your LinkedIn profile, perhaps if you would like to connect, as well as the organization that you're part of. In the meantime, I would like to introduce someone who is going to read a very short poem for us that's focused on AMR. And I think it's just perfect because it's going to bring our mood and yeah, just it's going to be nice. In the person of Moses, Ogoti Moses. So I don't know if Ogoti Moses is on the call and if he would like to just share his poem quickly. Keep the comments coming, please. Your name and your LinkedIn profile, as well as the organization you're part of. Hi, Moses.
Please, I think that he can't unmute, so waiting for the host to make the unmute option available for everybody.
Okay, great. We would just wait a minute then. Okay, we have.
Hello.
Hi, Moses.
Hello, everyone.
Hi, we can hear you loud and clear. Please go ahead.
Are you with your phone? Okay.
Moses, can you get us?
Hello.
Yes, you have the floor.
Hello, everyone. I hope you can hear me.
Yes, we can. We can hear you.
Okay. Sorry for taking your time. My network was bad. But my name is Ogoti Moses, all the way from Kenya. And without wasting time, I am a pharmacist and also a poet. So I'll give you a poem with the title Antibiotic Stewardship. So you see, the last time I had microbes are plotting a coup, organizing a herd, a rebellion against antibiotics. Now that's antimicrobial resistance. Now the alarming, ringing louder, yet we lack persistence. Antimicrobial resistance is like your alarm clocks during exam week, and it's alarming. And we hide, but no one seems to seek. The pharmacist bells ringing loud, but it seems our calls are lost in the crowd. Now, even pharmacists with Adam's apple wako naive, because it hasn't rung a bell. Now, just feel the beating of the AMR canes. Now, the patients have become their own doctors because they are no longer patient. Even in drought, self-diagnosis reigns, leaving patient care complacent. Now, our voice on antibiotic stewardship is like a brand drug after 20 years because it's no longer patent antibiotics. Forced into early retirement because currently most of them ain't working. They became Johnny Walker. Instead of running, now they're just walking. And the microbes find it stunning. Self-medication is today's favorite menu. Nigerians can confirm that apart from jollof, antibiotics are the order for the day. Tell me that is your love. Kenyans can attest apart from ugali, amoxicillin is the daily special. Some random sneeze and cold achoo, azithromycin given without diagnosis in sight. Now, most pharmacies are like grounds for selling ducks. Don't pretend you haven't heard the quacks. A profession ruined, its purpose left bereft. In Kenya, Cap 244 is currently silent. Some of the law enforcers are ignorant. Ask them to comment on AMR and they'll still say no cap. So we hide the disappointments now because even the regulatory bodies are also bored. Now antibiotics, know that prescribers are cold. The true pharmacist was snobbed when they were last called. Last time, amoxiclav was called when it wasn't even needed. Now, truth is, without antibiotic stewardship, even if antibiotics were taken to the salon, they will still know no peace. AMR surely got us in a plot twist. Antibiotics, heartbroken, now left in pieces. Effectiveness decreased. Now, patient skip doses, seeking quick relief, giving microbes the room to mutate and build their beef. Now, even with affordable housing still in AMR, there's no room for improvement. Now, even penicillins are heartbroken. Last time I checked, they were not wearing their beta-lactam ring. You see, with antibiotic resistance, even lactams ain't better. Pharmacists know, but now the reality ain't striking better. So microbes are having a field day because the doctors are not keen in the field. Blind prescriptions before blood cultures are done. Now, unfortunately, that's the current culture. Evidence-based therapy is the solution, but many skip that solid truth. But can we change the culture? Break the norm? Start a stewardship revolution and reform the storm. Antibiotics are God's gift entrusted in our hands. Pharmacists, stewards of these precious strands, yet prescribers ignore the WHO guiding light. And patients, are they prepared for this fight? So be aware before you prescribe. Take a moment to wait. Even if never been to Saudi, don't be afraid, Kuwait. Pharmacists, we are like innate immunity, frontline warriors. Now, as pharmacists, we must lead, reserving meropenem for cases of true need. Microbes mutate while we hesitate, pretending we are unaware until it's too late. So don't be confused with drama. It's time.
Network issue.
Hi, Moses. It seems like we lost you.
Yeah. It seems like we lost him.
And I was just enjoying the very interesting poem he was
The rhyme.
sharing, you know. It was just flowing, and I'm sure everyone is gonna agree with me as well. Well, we would just wait and see if he's gonna rejoin in few minutes. In the meantime, I can see that a lot of people are really sharing their LinkedIn page and also stating where they are from. It's nice. I can see somebody from Nigeria, University of Lagos, another person from Cameroon. Just guys, keep it coming, keep it coming. This is just a very great opportunity for you to network, to collaborate, to connect, actually. I think that's the best. And you never can tell from here, perhaps you could just reach out to each other, and who knows, maybe more projects from AMR would come out from this networking session. Because of time and because I can't see Moses joining in, I'm gonna ask some questions. Helena, do you want to say something?
No, I don't.
Okay, great. Yes, the session has really been amazing, actually. So I have a question for the audience, and that is, what was the highlight for you from this whole session? You know, the session has been going on for the past 2 days. Was there something striking from any of the speakers that really resonated with you and is like a take-home message for you that you'll be leaving this whole event with, and you're probably gonna practice moving on from here? Feel free to maybe raise your hand or mute yourself and talk. Anybody? Okay, I see Faith. Hi, Faith. Please remember to say your country.
Hi.
Yeah.
All right. I'm Faith. I'm from Kenya, from the University of Nairobi. And what I found so striking and insightful to me was actually the sharing by Dr. Wendy, where she said that most people take antibiotics for a toothache, which is really unnecessary. Most of the conditions that affect teeth can be solved by procedural, they can be solved by dental procedures rather than taking antibiotics. And the practice of also taking prophylactic antibiotics, yes, it's important, but it's not really as necessary. So there are lots of ways to approach the dental sphere in healthcare, because it's most of the time it's quite ignored, but it's quite important.
Hi, thank you so much, Faith, for sharing that. And I do agree. I think one of the sessions that I really enjoyed the most was Dr. Wendy's session, perhaps because I haven't really been so used to the old dental space and antimicrobial resistance, but she really did justice to, you know, connecting the dots. And yes, the fact that it's not all toothaches that really require antimicrobial resistance. I can see Habib's hand is up. Hi, Habib. I hope I can call you Habib anyways. Please state your country and yeah, what was your take-home message from today's very amazing session, or perhaps yesterday's one as well?
Yeah, good evening, everyone. I'm Habib from Benin City, Nigeria. Although I was not able to attend the one of yesterday, I had a busy schedule, and it was the one of today. It was really interesting. And the funniest part of it was I was on the program at work, and when I was coming back, even on the taxi, people were looking at me weird, and it was really funny for me, but I didn't wanted to miss any part of it. From Dr. Wendy to the panel, I really enjoyed it. And my take home for today will be from the panel, how they are inspired stories, how they started, how they've been able to. I don't know if you can hear me.
Loud and clear. We are hearing you.
Can you hear me? Sorry.
Yes, we can.
Right. How their stories from Farm Estelle to Farm Yusuf Babatunde, and as well as Sir Daniel, how they've been able to organize and raise awareness with their own little resources, and as well as how the national body and they really don't give it the way they were supposed to take it. We like here in Nigeria, you see NDLEA everywhere on the roadway and traveling to cities like Abuja and Lagos and Benin here. I know plenty of times they stop our vehicle and search, but that is not the real deal here. We are looking at AMR, and it's a big silent epidemic that people don't even know about. It's killing a lot, and they don't really know about it. So it gives me I feel like I should look for a way. Let me start in my rural area. Let me leave the urban area. Let me go to the rural area where they don't have access to medical care. They just go to any local pharmacist that, of course, the pharmacists are not qualified pharmacists. They're just shopkeepers. So it really pains me as a biochemist one, and seeing they are going into something they don't understand, and we have no way telling them go to the hospital. We tell you it's too expensive. They can just go to the pharmacy and buy something of just little money, but going to the hospital, you're going to pay consultation fee, buying a card and the rest. So it's like an inspiration for me to go back to rural areas and see how we can talk to these pharmacists, how they can reduce how they give out the prescribed drugs to these people. Thank you very much for the program. It's been really an interesting one.
Thank you so much, Abib, for sharing that. And I really do hope you do go back to the rural areas. And I will just quote what Fam Yusuf said, which is be courageous to start. Most of the time, it's always sometimes difficult, or we get cold feet about starting things, but yeah, be courageous to start. And I look forward to perhaps something impactful coming from you next year. I'm also glad that you were really able to learn so much, and I do understand how people would have probably looked at you as you were walking on the streets and you were listening. I was also had to work when the session started, but it was very captivating, it was very interesting, and I just couldn't help myself but to listen to it. So thank you so much, Abib. I see Milimo's hand up. In the meantime, guys, I see you guys are dropping your LinkedIn links. Feel free to connect as much as possible. This is such a very good avenue to do so. You're going to be meeting people from different countries, and yeah, you never know where this could lead to. Milimo, you have the floor, please.
Hi everyone, good evening. This is Milimo from Zambia. I'm coming from a youth-led organization, Alliance Against Antimicrobial Antipathy. Something that stood out for me ever since we kickstarted this year's African Youth AMR Forum 2.0 was discovering how the global goals, the global goals, SDGs, how they are connecting to AMR. Mainly, we focus much on only a few SDGs, like SDG 3, good health and well-being, SDG 6, clean water and sanitation, and maybe SDG 13, climate action. And the last goal which is partnership for the goals SDG 17. We do not pay much attention on these other goals and how they are interlinked to AMR. So in yesterday's session, it was thrilling to acknowledge how each and every SDG from SDG 1 to 17 is interlinked to AMR and how advocating for the success of these SDGs positively contributes to, lessening AMR emergency. So I think that was really incredible on this end. Thank you. This is my contribution.
Thank you so much, Minimo, for sharing that. And yeah, AMR kind of like connects to a lot of things, looking at the sustainable development goals like WASH and the other ones that you mentioned. And that is one of the reasons why I think antimicrobial resistance is such a huge threat because, it's cutting across different sectors and the likes. I see Oguntola's hand is raised up. Hi, Oguntola. We're just gonna listen for maybe another 2 minutes, then we could go to other parts of this networking session. So yeah, please, in about 2 minutes, please share what you've learned from this forum so far. Thank you.
All right. Good day, everyone. It's really, really been a nice time. And from yesterday, I learned from Dr. Paul how SDGs and then antimicrobial resistance are interrelated from good health and well-being to education for all and everything. Like it was really, really an amazing session. And today I was from Dr. Wendy. I learned from aura in relativity to antimicrobial because initially I've always seen, though I always fight against the use of antibiotics once you're having any kind of dental issue, but I'm not really, really knowledgeable in that field. But with what she taught today, like I'm really, really grateful for that. And also Dr. Punari from Indian lecture on the superheroes against superbugs. Like it's really, really amazing. I'm able to understand that we can use different, like we can use images, we can use how do I put it? We can use art, yes, to preach, to communicate antimicrobial to the younger children, to younger folks. And it's not just about we like medical people participating in this. We can call on art students, we can call on social science students, we can call on humanities students that are very, very good when it comes to fine art, that are very, very good in music, they are very, very good in acting, and then collaborate with them to create a message that is like very, very plain and understandable to the younger folks. And it's really like it have really, really been a nice session. And then to the panelist session, it was wow, the drive behind their passion for AMR and how we as youth we can also involve ourselves in data driven everything. Like it's really, really nice. Thank you very much.
Thank you for sharing that. It seems like Dr. Wendy really impacted a lot of people in this forum so far. That's really nice. And I do agree, listening to the panel discussion today about their passions and how they got really interested in AMR was really fascinating because everybody gets pulled to AMR for some reason, perhaps due to their own personal involvement. Maybe they became resistant to different antimicrobials and they couldn't find like a drug that could treat them, or maybe a friend, or for different reasons. So listening to people talk about their passion and what is driving them for AMR is really quite enlightening and motivating, because I felt very motivated listening to them, and I'm sure a lot of us would probably have felt that way too. So another part of this networking session that we would like, I'm sure you would also like as well, is talking about the projects that you might have with regards to antimicrobial resistance. So if you've been doing something relating to antimicrobial resistance, this is a very good opportunity to kind of like enlighten everybody about it. And I hope that we get motivated from each other. So yeah, you can just raise your hands and unmute and let's have a discussion. But before that, I'm sorry, I just realized that baby Musamba from Tanzania dropped a comment in the chat. She said, or he said, I'm not really sure at this moment. I apologize. The takeaway from the session so far is AMR is really and not supposed to be taken for granted. I learned that from yesterday, how we can involve ourselves in policy formulation, advocacy, and so on. Advocacy and policy are very key things that, we need to be more involved in when it comes to antimicrobial resistance. We need to advocate as much as possible. And we need to also be involved in creation of policies, policy formulation and implementation as well. So thank you, Misamba from Tanzania, for sharing that. So over to the project, I would like to hear some very amazing projects you may be involved in doing when it comes to antimicrobial resistance. Does anybody want to take the floor? Guys, don't be shy. Even if it's as little as just posting social media content on LinkedIn, I think nothing is really too small when it comes to the fight against EML, to be honest. So, yeah.
Hi, Miriam. Can you
Hi.
hear me?
Yes, I can hear you.
Okay. My name is Basil Izuchukwu from Nigeria. Sorry, I'm just trying to round up something. So I'll just be fast and probably get back to what I'm doing. So my little work on AMR, I think it all started when I was an undergraduate public health student. I came across AMR on the Global Health E-Learning Center that's supported by USAID. So I had wanted to use that for my seminar topic, though I was redirected by my supervisor then. But when I came back from my master's, I insisted, and yeah, I started talking about AMR. I used it for my seminar work, and having supported the Primary Healthcare Development Agency for more than 2 years and working with primary healthcare workers and knowing how relevant they are when it comes to disease prevention and even cure for communities. For some of them, they are the last hope of community members, where we have, especially in remote areas, you just have primary healthcare workers there, only the option community members had. I thought to myself, what if I just do a cap study with these guys on AMR, antimicrobial resistance? I had included stewardship initially, but my questions were much and then I had to reduce it. So that was my master's project. So I did a cap study with primary health. I call them primary healthcare prescribers because some of them, because of shortage of medical personnel, we have primary healthcare prescribers that are not even nurses. You see a facility that is being managed by CHOOS or JCHOOS and the rest. So I thought of assessing their knowledge, attitude, and practice with regards to antimicrobial resistance. And in as much as I had people who have known about AMR as a result of their experiences in the health sector, not necessarily via training or in-service training or whatsoever, there was a disconnect in terms of practice, those of them who have learned about it over the years, were more cautious in antimicrobial stewardship guidelines and trying to do the right thing. But that was very insightful for me, and also an experience with primary healthcare workers, because they're the first point of call for community members. And I thought to myself, if we can get it right from there, maybe we will get it right as a health sector, as a country, because our primary healthcare workers are very relevant in the lives of community members, especially community members who have them as the last option. And I think it's an area we need to invest in when it comes to AMR with primary healthcare workers. We need to invest in that area. They are often neglected. I remember one of my questions was asking if they've ever had in-service training on AMR. Most of them said no, that they've not, that the last time they heard about it was antibiotic resistance during their normal tertiary institutions, So that was a little experience I had, hands-on experience. That was my project. Just wanted to share. Maybe when I publish my work, I'll make it available to everybody. Thank you.
I thank you so much, Basil. I think that is easier for me to pronounce. So if you don't mind, I will call you that.
Sure.
Thank you so much. Yeah, thank you for sharing that wonderful insight. Um, I do agree with you actually, because most of the time in some places in Nigeria, really it's like you have somebody that is prescribing something for you, and the person isn't like an health professional or medically certified, if I may say so. So that is one area that we really need to work on. And I also like the aspect where you said that training of healthcare workers is also one aspect that probably maybe somebody on this call might be willing to take up and look into to see if there are gaps and if those gaps can be filled. Remember, I think one of our panelists mentioned that you should find the gap that you can fill and you should fill. So yeah, this is just putting it out there. Maybe somebody might look into that and work on that. I see Milimo's hand raised up. Hi, do you want to share?
Hi, yes, thank you so much for the platform once again. And this session is been very insightful. I'm enjoying so far. Yeah, Milimo here again, from Zambia. I'm coming from a youth-led consortium called the Alliance Against Antimicrobial Antipathy. We're working around creating communities that will be aware about AMR and its impact on global health. Our key focus is on sensitization, advocacy, research, and innovation as we try to make this AMR be known across the country, the region, and the globe at large. So we're working in so many approaches. We've done um, training programs with livestock, small scale farmers to just educate them about responsible use of antimicrobials in animal health, and also school going children, trying to sensitize them about antimicrobial resistance and how they can be vigilant to try and fight this global crisis. Other than that, we have an interesting project that we are trying to work on. We're trying to incorporate antimicrobial stewardship programs in healthcare training facilities, and we have developed a curricula that um, outlines AMS programs that we intend to incorporate into the already existing learning curriculum in the health faculties of higher learning institutions. So we're trying to put this to life, and we have done um, the baselines. So it's a matter of time then this project will be implemented, and we are going to put it in 6 higher learning institutions across the country here in Zambia, distributed according to the main provinces and the main teaching hospitals across the country. So we're looking forward to put this idea to life, and also calling on other youth-led consortiums around AMR for potential synergies. Let's collaborate where necessary and work together to ensure that we fight AMR, which is one of the fastest growing global health um, issue of our time. Thank you so much for this platform. Thank you. Thank you. Bye from Zambia. Thank you.
Thank you so much for sharing what you've been working on. Of course, feel free. I don't know if you've dropped your LinkedIn handle in the chat, but if you haven't, it could be a good idea to do so. Perhaps somebody may decide to connect with you and maybe collaborate to work on your project as well, perhaps. Um, Also, I think it may be a good idea as well, in case you're shy, you could always drop an Instagram link, a LinkedIn link, a Twitter link to what you've been doing when it comes to World Antimicrobial Awareness Week. So if perhaps you've done like an outreach program, you could drop that in the chat. If you've done like a quiz session or something, I think that would also be nice to drop in the chat so someone could probably see and get motivated to also do more. We would begin to wrap up this session because I know it's been a very long day and we have our last session tomorrow. So I want us to be rejuvenated and have enough time to rest so that when we come tomorrow, we are coming with so much energy for a wonderful last section. Before we go though, I would like to ask that what motivated you to attend this African Youth AMR Youth Forum 2.0? We had one last year. So was it that perhaps you attended the one last year? It was just very amazing and you needed to attend this one this year? Or was it a friend that dragged you along and was like, hey, I attended yesterday's session. It was very amazing. You have to come to today's session. What was your motivation for joining this call and remaining till this hour? Please, guys, you could type it in the chat. I promise to read, and you could always raise your hands as well. Okay, I see that Milima's hand is raised up again. I don't know if your hand was previously raised or if you would like to contribute on this new discussion point. But yeah, please feel free.
Yeah, thank you. Thank you so much. It was incredible last year during the World AMR Awareness Week when this African Youth AMR Forum was. I think that was the inception of it. It was incredible. At that particular time, I came across the post on LinkedIn from the International Pharmaceutical Students Federation African Regional Office, inviting African youth to participate in that forum. I think that was the first edition of it. I registered because I've been passionate about conversations around AMR and based on lessons learned from that very first edition. And I was prompted not to miss this one. I actually invited 10 colleagues to join in to this year's session, and I'm hoping that they have been part of this. So based on the previous one, I was prompted to surely not miss this one. And so far, we are learning a lot. Thank you so much to you organizers of this. Thank you.
Amazing. If I had right, you attended the first session and you were motivated to come for this session because the first one was very incredible and amazing. I hope this one was just as incredible, enlightening, educating, and motivating as well as the last one. Somebody said that was Oguntola. She's okay. I will start from Francis. Francis said that unfortunately she was not aware of the first forum, but when she heard about this one, she made it a point to attend and receive more insights on the threads posed by AMR and ways we can help it. Kudos to you for joining this forum. Oh, well, I mean, even though you couldn't attend the last one, I'm very, very glad and happy that you could attend this one. And I'm also glad that you found it very insightful. Oguntola also said the same. Okay, she said she attended the last year's session and it was very amazing. Yay! I'm sure the organizers of this forum must be very happy with the feedback that we are getting because yeah, it shows that we are really making a difference in the world and in Africa basically. Yeah, she said she doesn't regret attending it till now. That is very amazing. I'm so glad to hear that. Hope said she saw it on LinkedIn, and as someone that was interested in AMR, she registered and she's happy she has learned a lot. Looking forward to more of such workshops. Nice. Okay, I think there was somebody's hand that was raised up. Was it Michael? I don't know. Please, if you could raise your hand up again, then I could.
Hi, Mariam.
Hi.
Michael, I raised my hand, but I think I've left my comment, but I may still talk as well briefly.
Yes, please.
I was motivated. I think it was a brilliant idea to see that young Africans taking upon themselves to have a forum and hold discussions and educate one another. And I've loved the past 2 days, really enjoyed the conversations. And I think there's been a lot of ideas also bouncing around on how to get the message on AMR going out. So kudos to organizers, kudos to you, and to the host particularly. I think those from yesterday, yourself today, have been amazing. Well done.
Thank you so much, Michael, for sharing. I think one of the things that I really like a lot from this forum is the fact that a lot of people are really joining because they want to learn. And that's one thing that I think is very unique about youths and perhaps African youths is the fact that, we are always eager to learn. We are always eager to make impact. And I just want to urge each and every one of us to keep this drive going, to keep moving forward, and not just for the World Antimicrobial Awareness Week really, but moving forward, let's see how we can keep making impact within our continent, Africa, and perhaps in the world as a whole. We have some more comments. Okay, I'm gonna read from Pascal. Hi, Pascal from Tanzania. Right now I'm doing my internship program in my country. So far I'm very interested to know much about AMR development. However, I witness a lot of people around my society being doctors that everyone can prescribe medication without any confirmatory diagnosis or even tentative ones, and people widely use antibiotics improperly. I'm crying with you with that emoji that you've put there actually, because why would you just prescribe antimicrobials without even like a tentative diagnosis, a confirmatory diagnosis, maybe doing some tests or trying to find out the root cause of the problem? I really hope things are going to change in Tanzania. Thank you so much for sharing that. I didn't get a chance to attend the other one. This was the first one. Till now, I'm happy and well motivated on AMR. I was told by my friend and I didn't want to be left out. And from now on, I'm looking forward to the next and can't wait to miss it. Yay! I always love friends that carry their friends along. Those friends are friends that you should hold tight. And yeah, do say thank you to your friend for encouraging you to attend this session. I hope you would also motivate somebody else to attend tomorrow's session. And maybe that is gonna be like a to-do task for everyone if you're interested. So reach out to someone this night, tomorrow morning, and encourage them that there's gonna be one more session tomorrow. It's gonna be even much more impactful than the other two, and they have to join in. Okay, I've attended former IPSF Afro online events before, and they are always amazing. And this year, I decided to be intentional to attend as many as I can in this tenure to learn more. Yay, you go, girl. I hope it's a girl I'm talking to. But that's from Faith. I think I've also seen some IPSF Afro events in the past. And yes, IPSF are always doing very amazing and wonderful things. So I do agree with you on that point. I've got how it is important to interact with some stakeholders, scientists, and doctors. Also seen the power of storytelling with engagement strategies to combat AMR from Rwanda. Wow. Yeah, I do agree with you on the storytelling. I think when I'm not sure I can pronounce her name now, so I'm not gonna attempt it so I don't murder it. But yeah, when she was talking about the impact of storytelling, I was like, that is one part of media advocacy that I'm not sure a lot of people have explored. So maybe from here you could decide to engage in some storytelling, craft some very wonderful, interesting stories that people would like to read, but at the same time you're passing across your message. That is something worth exploring. Their African youth be part of the movement shaping the future of antimicrobial resistance advocacy. Join this advocacy amazing opportunity to change the advocacy narrative. So somebody has dropped someone from Dusit Blue, Mark. Dusit Blue Foundation has dropped a link, and this could be like an action point for you as well. In terms of advocacy. So yeah, do check that out as well. And it is in French. I think it's in French. I really
It's
can't tell.
bilingual, actually.
It's in what?
It's bilingual. There's an English
Ah,
and a French message. Yeah.
oh, okay, great. Well, it's also in English as well. So for those of us that
Yeah.
really don't know other languages apart from English, yeah, feel free to look at it. And yeah, this is my first time and I'm getting more insight about AMR. Wonderful. Does anybody want to give some last comments before we round up today's session? And just in the flow of talking about projects that everybody has been doing with regards to what antimicrobial resistance and what antimicrobial awareness week. Everybody, I've listened to everyone, so I might as well share some projects that I have been doing or have been part of. As the project manager of Africa PHSN, we are organizing this very amazing antimicrobial simulation exercise. It's going to take place on the 23rd. So do check out Africa PHSN's LinkedIn, Andrew. I'm going to drop it in the chat, and that is all I'm going to say. Let me leave some suspense for you to try to, yeah, glean some more information. Yeah, I'm really getting more knowledgeable on AMR from these presentations. I do agree with you. I've learned a lot, and this is even coming from me that I've been doing some things relating to AMR for the past few years. I see Ridwan's hand is up. Hi, Ridwan. Hi, you can unmute and talk, Ridwan. Am I still audible? Ridwan, you're muted.
Okay. Good evening, Doc.
Hi, good evening. Now we can hear you.
Yes. Well, I'm Muhammad Ridwan by name. Well, I don't even remember registering for the program, but I received an email which I attended the program. The program was amazing. Right from the day one, day two, the speaker did justice to the topic, talking about the innovation, the collaboration, partnership, capacity building, and it's even beyond AMR. Yes, what discussed here is beyond AMR. It's talk about someone's life. You have to be courageous. You have to start, no matter the knowledge or the information, just starts along the line. You know how to further or how to do better in whatever you are doing. This is a very amazing session I have attended, and I'm looking forward to attend more and also to invite some of my friends to also participate in this program. Thank you very much to the organizer. May God bless you.
Yay! Ooh, more positive remarks. I love it. Ooh, that's wonderful. Thank you so much. Guys, we need to drag our friends to this because we can't be enjoying this alone. I'm sure you all agree with me. So please do bring your friends tomorrow. I want this whole session tomorrow's session to be very full, and we should be looking for how we should be sending YouTube links for anybody that wants to join on LinkedIn. Yeah, thank you so much. Okay, somebody is sending a shout out to me. Fatima, thank you. Nice to see you here too. I'm doing my own project on AMR as it is where my interest is deeply rooted. It has been a great research and hope the findings will be helpful for our continent. Yay, the person saw this on LinkedIn. I don't want to murder your name, please. But yeah, from Ethiopia, she said she saw or he saw this on LinkedIn and was very motivated to attend. Guys, I think I'm gonna be closing this meeting now because I'm sure some people is probably late in their time zone. It's 7:12 over here. So yay. Looking forward to seeing you tomorrow. I don't know if Elena has any last words before we wrap up today. But yes, it's been wonderful interacting with everybody, learning from your experiences, connecting with you, and cheers. I look forward to more wonderful collaborations, projects coming out from this session or this whole forum. Yeah.
All right. Thank you very much. So I saw some people asking for my contact in the chat box. I have sent it. So you can as well just write me and we'll connect on WhatsApp. I sent my LinkedIn profile earlier, so I'm waiting for all the connection. Also send connection invites to those who drop their LinkedIn. So I look forward to connecting with all of you here, because that's actually the aim of this forum. Let's not just come and learn. Let's also connect with each other. So I want to thank all of you for joining, and tomorrow is the last session, and there's still more for us. So I'm looking forward to having all of us here tomorrow, same time, 2 p.m. And also another reminder, I believe that we received emails about filling some forms. Please do well to fill the form, because that is what we are going to use to generate a certificate. The pre-evaluation survey, if you haven't filled it yet, please do well to fill it. It takes less than 5 minutes. And tomorrow after the session, we are going to share the post-evaluation survey so that you should fill. So it's only those who fill the pre and the post survey that will have access to, they'll be eligible to get their attestations for participating in this forum. So thank you all very much. Before we end, I would like us to take a picture. So please don't be shy, don't be shy. Switch on your cameras. We'll give you 2 minutes to switch on your cameras, and let's take a picture. The picture is evidence that you were for the forum. If we end the forum without any picture, no evidence. So let's take, right. All right. So please let's take out. Okay. Please don't be shy. Don't be shy. All right. So okay. So I see that we have 5 screens. So I will take each screen. Don't worry. I will share the pictures to your emails tomorrow. I will share the pictures. All right. So we'll give 30 seconds more to those who are wasting time before we start taking the pictures. Yeah. Okay. So let me start with the first screen. Let me arrange my face. All right. Okay, let me move to the second screen. This second screen, it's like we are shy. Please switch on your cameras now. Oh, I'll just take like that. All right. Okay. All right, let me retake. I'm in the second screen now. Okay. It's like some people are still trying to switch the camera, so let's just leave 30 seconds for them. All right. All right, let me move to the, okay. Next screen. Wow, we are really many in the call. Okay, the third screen. The fourth screen. All right. So even though some of us were shy, I still took some. All right, that is great. So see us all tomorrow. And also before I forget, I heard some of us say that we did not attend yesterday's session, but luckily our media team streamed the session on YouTube. So those who could not attend yesterday's session, we are going to be at the end of after tomorrow Wednesday, we'll share you the links of all the 3 days so that you can always catch up, and it's always going to be there. It will be there for as long as possible. Any other time that maybe you have forgotten something, you want to refresh your mind, you can always go to the YouTube video and rewatch. So thanks very much to the media team for making that possible. Thanks, Mama Hope. So that's it. We have come to the end of today's session. So this is the point we say bye-bye and see you all tomorrow.
Bye, guys. Bye. Good night.
Night, night, night.